this webinar, Glaucoma Management in a Nutshell, organized by the Ophthalmology Department of Little Flower Hospital, Angamali. The academic session is divided into two modules, the diagnostics and treatment modalities. We'll be focusing on both the basics and recent developments, and we are sure that will be beneficial for the general ophthalmologists as well as the glaucoma specialists who attend. Now let's move on to the inaugural function. Over to Dr. Danya.
Thank you, ma'am. A very good morning to all. Myself, Dr. Danya. Let's call upon dear Dr. Elizabeth Joseph for the welcome speech. Ma'am is the HOD of Ophthalmology and Chief of Pediatric Ophthalmology and Strabismology at our Little Flower Hospital, Angamali. Welcome, ma'am.
Thank you, Dr. Danya, for inviting me. Am I audible? Am I audible?
Yes, ma'am.
Yes, ma'am, you are.
Yes.
Okay.
Yes.
Respected Director, Father Verghese Pottagal, President of KSOS, Dr. Arup Chakravarti, President of Cochin Ophthalmic Club, Dr. Shashi Kumar, Medical Superintendent of LF Hospital, Dr. Stevie Joseph, Organizing Secretary, Dr. Girija, distinguished faculty members, delegates, friends, colleagues. Good morning to all of you. The Department of Ophthalmology, Little Flower Hospital, Angamali is extremely happy to organize and present this CME, Glaucoma Management in a Nutshell. And it is my privilege to propose a welcome address. We are extremely happy that our Director, Father Verghese Pottagal, has consented to give the presidential address today. Father Director is always the source of inspiration for all of us. He is a visionary working to improve all the departments of LF Hospital. I welcome Father Director to this inaugural function and request you to deliver the presidential address. Hearty welcome, Father Director. The KSOS, under the able presidentship of Dr. Arup Chakravarti, has advanced leaps and bounds in the academic field. He has organized excellent innovative programs for the improvement of KSOS. Dr. Arup is an international figure with a very reputed academic achievements, and we are very happy that you could spare some time to inaugurate this CME and deliver the talk on medical management of glaucoma. We welcome Dr. Arup Chakravarti and look forward to your words of wisdom in glaucoma management. Welcome again, Dr. Arup. Dr. Stevie Joseph is the medical superintendent of LF Hospital. He is a very eminent cardiologist, and we are happy that he could spare some time for us in spite of his busy work schedule. Cordial welcome to Dr. Stevie, sir.
Thank you, ma'am. Thank you.
Dr. Shashi Kumar, President of COC, is a great friend of ours. He is always on the academic front, and we all have learned a lot from you, Dr. Shashi. Welcome, Dr. Shashi, to this meeting.
Thank you, ma'am.
We have esteemed faculty members today. I welcome Dr. V. Ganesh, Dr. Raju Parekh, Dr. George Puthuran, Dr. Venkatesh, Dr. Manju Anup, Dr. John Davis Sakara, Dr. Litta, and our own Dr. Smita VK to this webinar. We welcome all delegates, all members of LF family, members of Cochin Ophthalmic Club, and members of Kerala Society of Ophthalmic Surgeons. Dr. Girija has done a marvelous job in arranging this program, and all the credit of this CME goes to Dr. Girija mainly and the entire glaucoma department. Welcome, Dr. Girija. Also, please accept our gratitude. Once again, I welcome each and every one of you. Have a great academic feast. So, once again, welcome all.
Thank you, ma'am, for the warm welcome. For the presidential address, may I call upon Father Verghese? Father is the director of our center.
Morning.
Am I
audible? Am I audible?
Yes, Father, you're
Yes,
audible. You're audible. Yes.
Respected Dr. Arup Chakrabarti, President, Kerala Society of Ophthalmic Surgeons, who inaugurates this CME. Dr. Stigi Joseph, our EMS at Ella Hospital, Ankamali. Dr. Shashigumar S., President, COC. Dr. Elizabeth Joseph, Chairman of Organizing Committee. Dr. Girija K., Secretary, Organizing Committee, both from Ella Hospital. Renowned speakers from various institutions, respected ophthalmologists, delegates, PG students, and participants of this annual CME. A very good morning and warm greetings to one and all. Little Flower Institute of Ophthalmology and Research Center, Ankamali, is proud to host this annual CME of ophthalmologists. The theme of the day, glaucoma management in a nutshell, is indeed a relevant topic that needs our particular attention. With the growing and aging of population, it is expected that in the future, the prevalence of glaucoma will continue to increase, causing lifetime risk of blindness for many. Existing glaucoma treatments aim to reduce eye pressure, to slow the progression of disease and prevent permanent damage to the optic nerve. However, there are some clinical trials underway, the findings of which eventually may lead to more advanced and precise glaucoma treatments. Potential therapeutic managements of glaucoma by biannual injections instead of eye drops and surgery, antifibrotic therapy to treat open-angle glaucoma, new gene therapy to reverse the age of cells and recapture youthful gene function that may revolutionize the treatment, and new technologies like direct selective laser trabeculoplasty and Urista Bimatoprust Implant, etc., can open up new horizon in glaucoma management. Despite recent advances in techniques that allow establishment of earlier diagnosis and treatment initiation, significant numbers of glaucoma patients are undiagnosed and present late in the course of disease. This can lead to irreversible vision loss, reduced quality of life, and a higher socio-economic burden. Hence, in treating glaucoma, a leading cause of irreversible vision loss worldwide, results of new scientific researches are to be adopted. LF Hospital, earlier popularly known as Eye Hospital, is committed to scientific research and advanced studies in various fields in ophthalmology. We also conduct various free eye camps to identify eye-related diseases and also offer surgeries, either free or reduced rates, to help the needy. In this way, we take advanced knowledge in ophthalmology to the people at large and especially to those who are in need. It is our social commitment. I congratulate the LF team that has taken pains to host this webinar today. COC has undertaken this CME specifically with an intent to ensure optimal visual outcome through glaucoma management. I thank all of you for your dedicated service to humanity and for your participation in this CME. I wish you all great success in your ardent desire to update yourself with new scientific ways and means in managing glaucoma. I wish every success for today's webinar and wish all of you God's blessings. Thank you. Have a great day.
Thank you, Father, for the inspiring speech. To inaugurate and give us a few words on the day, let's call upon Dr. Arup Chakrabarti, President, KSOS. Welcome, sir.
Good morning, friends. At the outset, I'd like to thank Little Flower Hospital Director Father Varghese, Elizabeth Madam, Thomas, Dr. Girija, and Dr. Shashi Kumar, the President of Cochin Ophthalmic Club, for asking me to participate in this inaugural program as President of Kerala Society of Ophthalmic Surgeons. I represent all the other office bearers in the society for this meeting today. Little Flower Hospital has been at the forefront of ophthalmic care for a very long time. Even before I came to Kerala a couple of decades earlier, all of us all over the country could feel the ripples of the wave which Little Flower Hospital was creating in ophthalmic care and ophthalmic education in Kerala. And I got to see firsthand when I settled down in this God's beautiful country, state. And they have been doing high volume work, and always latest state of the art technology is being used. They have been organizing CMEs on a very regular basis. Even in the COVID time, webinars have been going on. And for this particular webinar, I must congratulate Dr. Girija, for not only meticulously planning each and every aspect of the CME, contacting all the speakers, sending the links, sending the background design. When I have very rarely come across an organizer who has performed so meticulously and so much ahead of the calendar. So thank you, Dr. Girija, for all your efforts. A little bit about Kerala Society of Ophthalmic Surgeons here, our society. Thank you, Dr. Girija, Dr. Elizabeth Manna, for your kind words. We have been able to bring in a few changes thanks to our dynamic secretary and chairman scientific committee. We're going to have the Drishti meeting in Kozhikode, and for that registration process, online registration process is already started. The scientific submitted program and the free papers evaluation have already started, and you should be hearing from the scientific committee in a couple of weeks' time. I'm sure you're going to have a very good scientific program. Dr. Gopal has been busy not only as a secretary, but also organizing those every Wednesday, the PG classes, the PG classroom in a very meticulous manner. We have also tried to streamline the activities of KSOS so that subsequent batches of office bearers who join will not find himself or herself out of place and immediately can join the mainstream. A lot of SOPs, again, thanks to the effort of Dr. Shashi Kumar, who I turn to for guidance whenever there is an issue, whenever I am faced with some obstacle as to how to proceed in a proper way. Thank you, Dr. Shashi, for envisaging a lot of changes which we are planning to incorporate. I've already streamlined, and all these conferences, CMEs, everything is now through the vendors, and so that all the scientific committee secretaries, the scientific committee chairman, the secretaries find it much easier to conduct the online affairs of KSOS. And regarding today's program, the glaucoma management in a nutshell, very nice topics, but very interesting and very important topics. We have a timeline, so I hope we will be able to maintain the timeline. And we have speakers of national and state eminence participating today. So warm welcome to all of them. And with these words, I really wish the particular webinar, Glaucoma Management in a Nutshell, all the best. And I hope it will become a great learning experience for the viewers. Thank you so much.
Thank you, sir, for the inspiring words. We plan to continue all our work, and we expect your kind support through the same. Next, for felicitation, we welcome Dr. Stigi Joseph. He's a medical superintendent and chief of cardiology. To you, sir.
Respected Reverend Father Varghese Kottakkal, Director, Little Flower Hospital, Dr. Arup Chakrabarti, who inaugurated this webinar, Dr. Elizabeth Joseph, HOD, Ophthalmology Department, LF Hospital, Dr. Shashi Kumar S., President, Cochin Ophthalmic Club, Dr. Girija K., Glaucoma Specialist and Secretary, Organizing Committee, and all faculty, delegates, and colleagues. It's a great privilege to felicitate in this wonderful webinar. And I congratulate Little Flower Hospital Ophthalmology Department for conducting this program. And I know the pain Dr. Girija has taken. Just for a felicitation, at least 3 times she has called me and informed about the timing and everything. And on behalf of the hospital, I congratulate you as well as thank you for conducting this conference. I express all my prayers and whatever help I can do for the conduct for this conference. And also I thank Dr. Elizabeth Joseph, who is the head of the department. And once again, my prayers for the wonderful conference. Thank you.
Thank you, sir. Thank you for your prayers. We welcome Dr. Shashikumar S., President COC and former President KSOS, to give us his felicitation for the day. Sir.
Oh, sorry. Good morning to all of you. We are slowly coming out of the restrictions COVID has imposed on us, and many CMEs and social events have become physical now. Virtual meets have offered many advantages and conveniences to the organizers. They can call delegates, they can call the faculty from anywhere in the world now. The delegates can attend the conference from the comfort of their home. So all these advantages are there, but still the thrill of meeting fellow ophthalmologists and interacting one-to-one with the faculty and others are all missing in virtual meets. But now that the WHO has notified monkeypox also as a disease of grave concern, which is next to calling it a pandemic, we have to be very prudent in organizing physical meets, and I think LF is justified in conducting this glaucoma CME as a webinar. Little Flower Hospital has always been in the pioneers in specialty eye care in Kerala for many years. They were also in the forefront to conduct excellent CMEs for postgraduates and general ophthalmologists and specialists. This time, LF has chosen to conduct, to highlight glaucoma, and has made an excellent program with very good faculty and very good topics. I'm sure the deliberations during this CME, which will be available on YouTube for future, will enlighten the delegates who have joined now and others who plan to enjoy at their convenience. I thank the Little Flower team, especially Dr. Girija, for inviting me to be part of this event. I, on behalf of all the COC members, wish the CME every success and wish all the delegates an academically enriching Sunday. I also take this opportunity to welcome all of you to attend the August Ophthalmica, which will be held on August 14th, and which will be a physical event. Thank you.
Thank you, sir, for the kind words. Before we enter the academic session, I would like to call dear Dr. Girija, who has meticulously planned our CME for the vote of thanks. Ma'am is the chief of glaucoma department at our center. Ma'am, to you.
A warm and graceful morning to all those who have joined us for this webinar. It's my privilege to propose a vote of thanks and acknowledge the contribution of all those who have worked really hard to make this event possible. First, on behalf of the entire fraternity of the ophthalmology department, let me extend my sincere thanks to the Almighty for making this event possible. On behalf of our department, I extend a hearty vote of thanks to our director, Father Varghese Pottekal, who, in spite of his busy schedule, spared time to grace this occasion and inspired us with his encouraging words. Thank you, Father. I offer my sincere thanks to Dr. Arup Chakravarti, President of KSOS, for his active participation in this event. And thank you, sir, for your kind words. Your deep and intellectual way of imparting knowledge has added to the glory of this event. My special gratitude to Dr. Stiji Joseph, the medical superintendent, who has agreed to propose felicitations. And I express my sincere thanks to Dr. Shashikumar, President of Cochin Ophthalmic Club, for readily agreeing to offer felicitations for this event. I'm really grateful to Dr. Elizabeth, our head of the department, for entrusting me with this responsibility. It was Madam's idea to have our annual CME this year on glaucoma. Even though we wanted to have a physical meeting initially, In order to spare the inconvenience of traveling to the faculty and delegates and several other reasons, we decided to go with a webinar. Madam supported me throughout in all my decisions and efforts. My sincere thanks to you, Madam. A special thanks to Dr. Thomas Cherian, Head of the Department of Retina, who is my dear friend and classmate, for guiding me through each and every step and correcting all my mistakes, however silly they were. I want to extend thanks to all the speakers who have agreed to participate, and I appreciate their efforts for making the event informative and beneficial for all of us. A special mention of Dr. George Puthuran, who, in spite of being unwell, will be joining us with his talk, and Dr. Venkatesh, who has shared his recorded talk as he had to be away on a trip. I am grateful to KSOS for providing the Zoom platform and the technical personnel for this event. An event like this cannot happen overnight. It requires planning in detail, and the wheels started rolling months ago. I have been fortunate enough to be backed by a team of very proactive and dedicated colleagues, postgraduates, and staff, and I take this opportunity to thank each and every one of them. I thank all those who have joined us for this webinar and request everyone to remain with us till the end of the program. Thank you.
Thank you, dear ma'am. We are extremely privileged and lucky, I would say, to have an array of national experts in the field to give us a concise, simplified, and yet clear understanding on the subject. So let's start, shall we? Please post your queries in the comment box, which will be discussed at the end of the module. Now moving on to the diagnostic module. The diagnostic module starts with a session on gonioscopy, the pearls on which will help us in accurately performing and diagnosing angle structures and abnormalities. Let's call upon dear Dr. Smita Wike, glaucoma consultant and LF since 2015. She completed her MS in ophthalmology from Calicut Medical College and fellowship glaucoma from RIO Bangalore. Welcome, ma'am. To you.
A warm welcome to all of you. My topic is pearls in gonioscopy. As you all know, gonioscopy is a clinical technique My topic is pearls in gonioscopy. As you all know, gonioscopy is a clinical technique used to examine the anterior chamber angle structures. In 1907, Tranders was the first to examine the anterior chamber angle in a keratoglobus eyes by indenting the limbus. He coined the term gonioscopy. Salzmann is considered as the father of gonioscopy, and he introduced the gonio lens to observe the angle. Normally, the angle of the eye is not visible to naked eyes as the light undergoes total internal reflection. When light rays passes from one medium to another with a different refractive index, if the angle of incidence is less than critical angle, it undergoes refraction. If the angle of incidence is equal to critical angle, it undergoes refraction at 90 degrees. And if the angle of incidence is more than critical angle, it undergoes total internal reflection. In the eyes, the light emitting from the anterior chamber angle undergoes total internal reflection as the angle of incidence is more than that of the critical angle. With the gonio lenses, they have the refractive index similar to that of the cornea, so that the light rays emits from the cornea through the lens and is refracted in case of gonio lenses and is reflected through the mirror in case of gonio prisms. Gonioscopy is indicated for diagnostic and therapeutic purpose. For diagnostic purpose, it is used to identify whether the angle is open or closed. If it is closed, whether it is synovial closure or appositional closure, and to identify any abnormalities in the angle like pigmentation, neovascularization, pseudoexfoliation, foreign bodies, and other congenital anomalies. It is used for therapeutic purposes like laser trabeculoplasty, excimer laser trabeculotomy, goniotomy, gonio-photocoagulation, and laser suturolysis. Gonioscopy can be direct or indirect. Direct gonioscopy is done with a steep convex lens. It allows the light to exit closer to the perpendicular at the lens-air interface. Couple lens is the prototype lens in this. It is done with a handheld slit lamp or binocular microscope, and the patient has to lie down supine. The advantages are it has greater flexibility, have a panoramic view. It can be used in sedated patients and infants. It provides a straight view, and we can observe both eyes simultaneously. Disadvantages are it is cumbersome and inconvenient. Patient has to lie down supine, and angles can be falsely closed with undue pressure on the lens. It provides less magnification and poor details. In indirect gonioscopy, the light rays are reflected by a mirror in the contact lens onto the examiner. It provides a mirror image of the opposite angle and is used in conjunction with slit lamp. There are two types of indirect lenses, scleral lenses and corneal lenses. Scleral lenses have a wide diameter and a steep curvature. So a viscous coupling fluid is required to fill the gap between the lens and the cornea. And Goldman, 1 mirror, 2 mirror, 3 mirror, 4 mirror, and 6 mirror lenses are there. Here you can see a D-shaped lens. This mirror is used for D-shaped mirror is used for seeing the angle. The central mirror is used for seeing the optic disc, and the other mirrors are used for seeing the retina. It cannot be used for indentation gonioscopy as the lens diameter is more than that of the cornea. Indentation lenses are 4-mirror lenses. This size mirror has an detachable handle. Posner mirror has an attached handle, and Sussman lens is finger held. All these mirrors need only 11-degree rotation to see the entire angle. These lenses have a base and radius of curvature similar to that of the cornea, so there is no need of any coupling fluid. And these lenses can be used for indentation gonioscopy. Advantages of indirect lenses are they are convenient to use. They have excellent view utilizing slit lamp optics. We can see the optic head. This corneal lenses can be used for indentation, and manipulative gonioscopy can be done with both lenses. While the disadvantages are we cannot compare both eyes simultaneously. It gives an inverted image. False closure of the angle can occur by the pressure caused by the scleral type lens, and artificial widening of the angle with corneal lens. We have to use viscous fluid in case of scleral lens, which makes the cornea hazy and makes it difficult for further examination. Gonioscopy should be done in a dim lit room with a short beam of light and minimal magnification, and particular care should be taken to avoid illuminating the pupil, and patient's gaze should be in primary position. You have to explain the procedure thoroughly to the patient, make the patient comfortably seated in the slit lamp, and anesthetize the eye. And if you are using Goldman lens, you have to fill coupling fluid. Ask the patient to look up, and you can separate the lids with the forefinger and thumb, and you can keep the lens in the lower part of the globe exposed, and then angle the lens backwards to the eye. Special techniques like manipulative gonioscopy and dynamic or indentation gonioscopy is done when the angles are narrow. Manipulative gonioscopy is done to view over steep iris. It's done by asking the patient to look into the direction of the mirror or moving the mirror towards the angle to be viewed. Indentation gonioscopy is useful when the iridocorneal angle is narrow. We can differentiate appositional from synachial angle closure. We can measure the extent of angle closure, identify the plateau iris configuration, and lens-induced angle closure. Indentation gonioscopy is done with corneal lens. When we indent the cornea, the aqueous in the central part is pushed to the periphery and the iris is brought posteriorly. This is a closed angle. On indentation, you can see the angles getting open. It is only a positional closure. While in synachial closure, the angle widens, but the iris trans still remains attached to the outer angle wall. Here you can see posterior synachial, peripheral anterior synachial. In plateau iris on indentation, you can see a double hump side. The peripheral iris cannot move posteriorly. It is bulged anteriorly as the ciliary body is positioned anteriorly in this case. We have to know the normal angle anatomy, gonioscopic view, before identifying the abnormalities in the angle. So starting from the root of the iris, you can see the ciliary body band, then the scleral spur, trabecular meshwork, posterior part, posterior pigmented part, and an anterior non-pigmented part, and the Shalby's line. These are the normal angle structures visible. In iris, we have to see three major things. That is the contour of the iris, site of iris incission, and angulation between the iris incission and slope of inner cornea. You have to see the presence of pigmentation, atrophy, tumors, etc. Iris processes are fine finger-like processes that extend into the scleral spur. They follow the concavity of the recess. And underlying structures can be seen in this. This iris moves with indentation, while it should be differentiated from peripheral anterior synachiae, which are broad. They extend beyond the scleral spur. They bridge the concavity of the recess, and they obscure the underlying view. Ciliary body band is a portion of the ciliary body which is visible in the angle. It is dark brown or gray in color. Width of the band depends on the level of iris incisation. It is wider in myopia. Scleral spur is the anteriormost portion of the sclera. It is white to light gray in color. Trabecular meshwork, you can see anterior to scleral spur. It is a non-pigmented anterior part and a pigmented posterior part. Pigmentation is more heavier in the inferior quadrant. If the pigmentation is heavier in the superior quadrant, you have to suspect pigment dispersion, pseudo-isolation, etc. Lens canal is not visible normally. Presence of blood makes it visible. It is seen in conditions with high episcleral venous pressure, as in kinetica, cavernous fistula, Sturge-Weber's syndrome, etc., or when the scleral gonial lens is pressed too hard. Shalby's line is the most anterior structure in the angle. It is the termination of decimus membrane. It's a thin, opaque white line. Shalby's line and scleral spur are the most consistent landmarks in the anterior chamber angle. Shalby's line can be identified by using a corneal verge. This thin slit beam is placed 10 to 15 degrees from the ocular, and you can see two reflections on the cornea, one from the outer surface of the cornea and one from the inner surface of the cornea. These two reflections meet at the Shalby's line. Here, the three-dimensional parallel pipe line is converted into a two-dimensional line of bright luminance. The importance of Shalby's line lies in identifying the importance of corneal verge lies in identifying the Shalby's line. Here you can see pigmentation anterior to Shalby's line, which can be confused with the trabecular meshwork. The trabecular meshwork is uniformly pigmented, while Shalby's line is non-uniform. Sambolysis line is non-uniformly pigmented, and you can identify the Shalby's line with corneal verge in this case. Grading of the angle can be done with different methods like Schafer's, Phase, Shears, and Rpc. Schafer's is the most commonly used method. If the angle width is more than 20 degrees, it is considered as open angle. And modified Schafer's is commonly used. Grade 4 showing ciliary body band, grade 3 scleral spur, grade 2 posterior trabecular meshwork, grade 1 is Shalby's line, and grade 0 closed angles. Shears is opposite the chapters with grade 0 showing ciliary body band and grade 4 the Sharpest line is not visible. Speed grading class takes into classification the insertion of iris root, angular width of the angle recess, configuration of the peripheral iris, and trabecular meshwork pigmentation. Rpc classification is based on the structures visible with grade 3 or less is considered to be narrow angle. Here you can see a closed angle. There are no angle structures seen in this. So occludable angle is it's an angle when the pigmented trabecular meshwork is not visible in at least 3 quadrants in primary position without manipulation. Here you can see a prominent Sharpest line. This is an open angle with pigmented trabecular meshwork and scleral spur. Prominent Sharpest line is seen in 10 to 15% of normal population, which is seen in conditions like accentual Rieger syndrome, where the iris strands is attached to this prominent ridge. In aniridia, the rudimentary stem of iris is seen in the angle. You can see the ciliary process as well. New vessels can be seen in the angle in this case. The new vessels are fine, arborizing vessels. They close the scleral spur. They are bright red in color, while the normal vessels are thick, they are short, they do not arborize, and they do not close the scleral spur. Here you can see a widened ciliary body band with the irregular widening of the ciliary body band is same case of angle recession glaucoma. In case of post-traumatic angle recession glaucoma, you have to compare both eyes, and if there is any asymmetry in the width of the ciliary body band, then you have to consider it as an angle recession. If angle recession is more than 270 degrees, then there is more prone for glaucoma. Here you can see a white area. It is the internal sclera exposed due to cleft in the cyclodialysis cleft, that is separation of the ciliary body from the scleral spur. Here you can see the separation of the iris from the root. In pigment dispersion syndrome, you can see a homogeneous dark band of pigment like mascara line of the trabecular meshwork and pigmentation anterior to the Sharpest line known as symbolosis line. It should be differentiated from the pseudo-exfoliation syndrome. In pseudo-exfoliation syndrome, the pigmentation is not so uniform and is not so dense also. And you can see for exfoliative material in the trabecular meshwork. Here you can see a foreign body in the angle, silicone oil in the angle. You can examine the patency of the ostium, tube of the implant. Once you have seen the done gonioscopy, you have to document the findings. You have to see, document the posterior structure visible in the primary gaze, the posterior structure on indentation, pigmentation of the trabecular meshwork, which is graded from grade 4, which is dense, 3 moderate, 2 light, and 0 none, and the iris configuration, whether it is flat, convex, or concave, and any abnormalities in the angle. You have to mention the eye, and all the 4 quadrants should be marked. Here, the posterior trabecular meshwork is seen in the superior quadrant, while scleral spur is visible in nasal and temporal quadrants, and the ciliary body band in the inferior quadrant with 1+ pigmentation in all quadrants except inferior, with a flat iris. For disinfection, wash the lens with soap and water, soak the lens for 5 to 10 minutes in diluted sodium hypochlorite solution, and rinse with sterile water and air dry, or you can wipe the lens with the isopropyl alcohol swab for 10 seconds, or use 2% glutaraldehyde or 1% formaldehyde. Gonioscopy remains the gold standard for evaluation of anterior chamber angle. In glaucoma patients, gonioscopy should be performed at appropriate intervals as the condition of angle is not static throughout life. Gonioscopy is an acquired art which needs a lot of personal experience. Thank you.
Thank you, ma'am, for the extensive class on gonioscopy, explaining in detail with pictures on each structures. It was very helpful. I'm sure we'll all come back to this class time and again to review on gonioscopy. Thank you so much, ma'am. Next, Goldman appellation tonometry has been our gold standard and go-to tonometry in our busy OPDs. But could there be a more patient-friendly and yet accurate method? What are the current trends in tonometry? Let's hear it from Dr. Lita George. She's currently working as a glaucoma consultant at Tony Fernandez Eye Hospital, Alva. She completed her long-term fellowship in glaucoma from Arvind Eye Hospital, Tirunelveli. To you, ma'am.
Am I audible?
Yes, ma'am.
Is my screen visible?
Yes, ma'am. Yes. Would you share the screen, please, ma'am?
Screen is not visible, so please start sharing.
It's not coming.
And there's a green button, share screen button.
Now is it visible?
Yes, ma'am.
So thank you, Girija Madam, for giving me this opportunity. So my topic is tonometry. As we know, measurement of intraocular pressure is very important in the management of glaucoma patients. Elevated IOP is no longer included in the definition of glaucoma, but still it remains the only modifiable risk factor in the management of glaucoma patients. So an accurate measurement of intraocular pressure is very important. So IOP is the pressure exerted by the intraocular condense on the cords of the eyeball, and it is maintained by a dynamic equilibrium between the aqueous humor production, its outflow, and the episcleral venous pressure. During the last 2 decades, there has been an increased search for newer tonometers, particularly because of the greater understanding regarding the influence of central corneal thickness and various other corneal biomechanical factors on Goldman appellation tonometry. And also, as more and more patients were undergoing refractive surgery, the accuracy of Goldman tonometer was being questioned. So an ideal tonometer, it should give an accurate measurement under all conditions. It should be easy to use, simple to calibrate, cost-effective, and should be free from maintenance issue. So measurement of intraocular pressure can be done using 2 techniques. One is manometry and the other is tonometry. Manometry is the direct measurement using a cannulation of the eye, and tonometry, it actually exploits various physical and physicochemical properties of the cornea and indirectly measures the intraocular pressure. In manometry, what you do is, here a needle is inserted into the anterior chamber through a bevel corneal wound, and it is connected to a tubing. This tubing in turn is connected to a fluid-filled reservoir, and this fluid-filled reservoir has got a pressure-sensitive membrane. And the movement of this pressure-sensitive membrane is translated into intraocular pressure. However, it is an invasive procedure, so the clinical applications are limited, and it disrupts the blood-aqueous barrier, causing release of prostaglandins, which in turn is going to alter the intraocular pressure and is mainly used for experimental and research work. Now, tonometry can be indentation tonometry or applanation tonometry. Chiodes is the prototype of indentation tonometer. And again, the applanation tonometry can be categorized into two, either the constant force with variable area, or it can be based on the principle of constant area with variable force. The example of constant area, the tonometers are Goldman, the Perkins, Drager's, Macular, Pneumotonometer, Tonopen, etc. And the constant force, the examples are Macular Tonometer. I'm just mentioning Chiodes tonometer. Chiodes tonometer is not very popular among the glaucoma practitioners these days, but still it's being widely used in community screening programs. Here, the amount of cornea intended by a given amount of force is measured and is used to calculate the intraocular pressure. The weight of the tonometer actually raises the pressure from P0 to PT, and the determination of P0 from the scale reading PT requires conversion, and that is done using the Friedenwald's nomogram, which is provided with the instrument. This is the Chiodes tonometer. It has got a fruit plate, a plunger. There is a weight. The usual weight is the 5.5 gram. You can increase the weight to 7.5 gram or 10 by adding additional weights. There is a holder, a needle, and a scale reading. The patient is made to lie supine, and the examiner sits at the head end and uses the tonometer and indents the cornea. I'm not going into the details of the procedure. Once you get the scale reading, you have to go to the nomogram, and from the nomogram, you get the corresponding intraocular pressure value. For example, with 5.5 gram weight, the scale reading is 6. Your IOP recording will be 14.6 millimeters of mercury with 5.5 gram weight. You have to also mention the time of recording. The advantages of Chiodes tonometer is that it is a very portable, inexpensive, and easy to operate instrument, and it is fairly accurate over a wide range of intraocular pressure. However, ocular rigidity is going to affect its value. High ocular rigidity produces false high IOP, and low ocular rigidity produces false low intraocular pressure measurement. And also repeated measurements can lower the intraocular pressure. Steeper and thicker corneas give false high IOP, and it is not suitable for gas-filled and oil-filled eyes. The next tonometer I'm going to mention is Goldman applanation tonometer. As we know, it is the gold standard tonometer and is widely used by all the glaucoma practitioners across the globe. The principle is the invert sphic loop. That is, the pressure inside a fluid-filled sphere is equal to the force needed to applanate the surface divided by the area of applanation. It is based on the assumptions that cornea is a dry surface, it is a perfect sphere, and it is an infinitely thin and flexible membrane. But as we know, cornea is not a dry surface, it is not a perfect sphere, it is not infinitely thin and flexible. So you have the modified invert sphic loop. Here the force needed to bend the cornea cancels the surface tension when the area of applanation is 7.35 millimeters square. Now this is the Goldman's tonometer. It is a slit lamp mounted device. The biprism, this is the most important part of the tonometer. Here you have the adjusting knob for taking the readings. Every ophthalmologist should know the Goldman applanation tonometry technique properly. Now coming to the slit lamp settings, you have to keep the slit lamp in minimum magnification. The illumination has to be maximum. The height and width of the beam also has to be maximum. Use the cobalt blue filter light, and the tonometer is placed in the slot. Now you have to orient the observing arm and the illumination arm at an angle of around 45 to 60 degree, and the drum reading has to be kept at 1, that is, which is equal to 10 millimeters of mercury. Now explain the procedure to the patient. Instill a drop of topical anesthetic and stain the cornea using a fluorescent strip. Place the chin on the chin rest, and the forehead has to rest against the forehead band. Ask the patient to look straight. Now move the slit lamp gently forwards. Initially, the examiner has to observe through the sides of the slit lamp. Move the slit lamp gently forwards. Just stop short of cornea. Now the examiner has to go to the eyepiece and observe through the eyepiece, preferably through the left eyepiece. So initially, when you touch the cornea, you will get something like this, a green dot like this. When you applanate it further, you will get 2 semicircular mires. This semicircular mires ideally should be of width of around 2 to 3 millimeters, and you will see that these mires will be pulsating in accordance with the cardiac cycle. Now you have to slowly turn the knob, and the end point is that the inner edges of the two semicircle has to meet in the mid phase of the pulsation. That is the end point of recording. Now, you can make certain mistakes. One is you can get very thick Myers that can lead to overestimation of the intraocular pressure. This thick Myers, of course, because of excessive stain. So what you have to do, you have to wipe the tip and the eye and pat dry the excessive dye. Now you can get thin Myers. Thin Myers can lead to underestimation of intraocular pressure. That is because of inadequate fluorescein. Then you have to reinstall fluorescein. You can get inaccurate vertical alignment, as shown in these pictures. That is a bigger upper Meyer and a smaller lower one, or a smaller upper Meyer and a bigger upper one. The principle is then you have to move the probe towards the larger one. Then there can be inaccurate horizontal alignment. Here, these circles have not met. You have to turn the knob in the clockwise direction and make the two semicircles meet and make the inner edges of the two semicircles meet. Here you have passed applanation. Now you have to turn the knob in the counterclockwise direction and make the two inner edges of the semicircles meet. Now in astigmatic corneas, the applanated area is elliptical. Either you can orient the axis of the minor cylinder with the red line or the A marking, which is at 45 degrees, or you can take the readings both in the vertical and the horizontal meridian and take the average of both the values. There are certain conditions where you can overestimate the IOP. That is when the Myers are thicker, when there is widening of the lid fissure, or if there is unsatisfactory vertical alignment, or elevating the eye more than 15 degrees above the horizontal. In thick corneas also, the intraocular pressure can be falsely high. Actually, the Goldman tonometer, it is most accurate in the range of corneal thickness of around 520 to 550 microns. When there is inadvertent pressure on the globe, there can be overestimation of intraocular pressure. And also for every 4 diopter of against the rule astigmatism, intraocular pressure is overestimated by 1 millimeter mercury. Then in the conditions where you can underestimate the intraocular pressure are repeated tonometry can lead to underestimation. Thick cornea due to edema gives a falsely low recording, and every 4 diopter with the rule astigmatism, intraocular pressure is underestimated by 1 millimeter of mercury. To summarize, Goldman applanation tonometry is the standard against which all tonometers are compared. Now, the next tonometer is the Perkins tonometer. It's actually very similar to the Goldman tonometer. It is a very portable and handheld device. Then the light comes from the batteries and the force comes from the spring, which is varied manually by the operator. The advantage is that it is a portable one, so you can use in supine position also, can be used in operating rooms, in infants, and it is accurate in both horizontal and vertical positions. And the Drager's tonometer is similar to the Perkins, and the force of applanation is supplied by the electric motors, and it is also a portable instrument. The next tonometer is the Macular tonometer. It is no longer available in the market. I'm just mentioning it because the TonoPen, which is quite popular these days, is based on the Macular principle. In Macular tonometer, there is a plunger, and the movement of the plunger is measured by a transducer and is recorded on a paper strip. See, this is the graph. This is the baseline graph. Once the plunger applanates the cornea, in the intraocular pressure slowly starts, the graph starts moving up. Then it forms a notch and makes a trough. And when you applanate it further, the intraocular pressure rises further. This difference between the baseline reading and the trough is an estimate of the intraocular pressure. This is the principle of the Macular tonometer. It is thought to be very accurate in scarred and edematous cornea. However, it is no longer manufactured. Now, TonoPen, the working is similar to the Macular. The principle is based on the Macular tonometer. It has got a disposable silicone sleeve, which is discarded after every patient. So the chance of transmission of infections is very less, and has been very popular in the initial phase of the COVID, where when we were not using the Goldman or the non-contact tonometer. It's a portable and battery-operated device. It has got a tip. The tip has got a microprocessor, which senses the trough force. And it analyzes whether the trough graph is of accurate shape. If the reading is not acceptable, it is rejected by the instrument. Around 4 to 10 measurements are taken, and that is averaged by the instrument, and an automatic display of the intraocular pressure is shown here together with the standard deviation. The advantage is it is very useful in community screening programs. It has got a very small area of aplanation, and there is little difference in intraocular pressure readings between the central and peripheral cornea, and it is reasonably accurate even over the amniotic membrane patch. However, it is not very accurate outside the physiological range. That is, it underestimates in high pressure ranges and overestimates in low pressure ranges. And also it tends to overestimate the intraocular pressure in band keratopathy, and also it is affected by corneal thickness. The next one is the non-contact tonometer. This is a very popular instrument used for screening purpose in the outpatient departments. Ideally, every patient who comes for an ophthalmic checkup should have a screening IOP recording, and NCT is the most popular device used for that purpose. Here, a force of air jet applanates the cornea. Together with the air jet, another collimated beam of light is also emitted by the instrument. This collimated beam of light goes and strikes the cornea and gets reflected back. And when it is reflected back, that is picked up by a photocell. When the area of applanation is around 3.6 millimeter in diameter, the light reflected by the photocell is at maximum, and the time required to produce the peak reflection is directly related to the force of air jet, which in turn is proportional to the intraocular pressure. That is the principle of the non-contact tonometer. The advantages are that it is useful for screening programs. It can be operated by non-medical person. There's no need for topical anesthesia, and there is no direct contact between the instrument and eye. However, the disadvantages is that at least 3, preferably 4 readings should be obtained on each eye, and is of questionable accuracy in post KPIs. And also in the initial period of COVID, it was being told that the force of air jet can generate aerosols, and these aerosols can act as a source of infection. However, I don't know whether it's clinically significant or not. The next tonometer is the dynamic contour tonometer by the Pascal. Here the principle is of contour matching. That is, if the eye is enclosed in a tight fitting shell, the force generated by the intraocular pressure would act on the shell wall. If you replace the shell wall by a pressure sensor, you would be able to measure the intraocular pressure. This is the instrument. It has got a prop. This prop rests on the cornea with a constant force of around 1 gram. And the prop has got a piezoelectric sensor. This sensor measures the intraocular pressure around 100 times in a second. It records both the systolic and the diastolic intraocular pressure, and the difference between the systolic and the diastolic intraocular pressure is called as the ocular pulse amplitude. This ocular pulse amplitude is an indicator of the choroidal perfusion. The drawbacks are it is more time consuming than Goldman. It is not useful in diseased cornea or after corneal transplant, and the readings tend to be a little higher, and the recurrent cost of the disposable tip. The next tonometer is the Rebound Tonometer, which was first described in 1997. This is the instrument. It has got a very small plastic ball together with a stainless steel wire, which is held in the instrument by an electromagnetic field. It has got a button. When you press the button, what happens is that the ball together with the stainless steel wire is ejected, and this goes and strikes the cornea. Once it strikes the cornea, there occurs deceleration. And this deceleration is measured, and that is correlated with the intraocular pressure. There is no need of topical anesthesia, no need of fluorescent. It has got a disposable prop, again, so the chance of transmission of infections are less. It is being used in home monitoring and can also be used in pediatric population. However, central corneal thickness affects the reading even more than in Goldman applanation tonometer. Now you have the transpalpebral tonometers. Theoretically, these tonometers can circumvent corneal problems like edema, astigmatism, and variation in thickness. And the examples are the phosphine tonometer and the TGDZ NOT1 and NOT2. And the next tonometer, which I'm going to mention, is the Ocular Response Analyzer. This instrument actually evaluates several biomechanical properties of the cornea and then corrects the intraocular pressure according to these properties. It provides 4 variables. These are the Goldman correlated intraocular pressure, the corneal compensated IOP, the corneal resistance factor, and the corneal hysteresis. Actually, the principle is based on the non-contact tonometer. Here, an air puff is generated. This air puff applanates the cornea. The cornea further moves inwards beyond the applanation. Once the air puff is shut off, the cornea comes back to its original position. So here you get 2 pressures. One is the applanation pressure during the inward movement, that is P1, and second one is the applanation pressure which you get during the outward movement of the cornea, that is P2. So the average of P1 and P2 is the Goldman correlated intraocular pressure, and the difference between P1 and P2 is the corneal hysteresis. The corneal hysteresis is an indication of the viscous damping in the cornea, and it is independent of radius of curvature of cornea, corneal astigmatism, visual acuity, or axial length. And in conditions like keratoconus, Fuchs dystrophy, and refractive surgery, corneal hysteresis is found to be reduced. And the final one is the Sensimid triggerfish, which is an instrument used for 24-hour IOP monitoring. Here, what you have is a soft, disposable hydrophilic contact lens. This has got an active anti-passive strain gauge, which senses the fluctuations in the diameter of the corneoscleral junction. This contact lens, it sends impulses wirelessly to an antenna, which is worn around the eye. From the antenna, the impulses are transmitted to the recorder through a data cable. From the recorder, the data can be transferred to the computer. So what the patient wears the contact lens, and he resumes all his routine activity, wears it for 24 hours, including the sleep time the instrument is worn. So you can get a continuous monitoring of the intraocular pressure. So thank you for your patient listening. So to conclude, the Goldman applanation tonometer is the gold standard tonometer, and that is the tonometer which is widely being used by all the glaucoma specialists, and various other tonometers have come into use, but still Goldman tonometer is the most common one being used. Thank you all.
Thank you, ma'am. It was a very detailed class. Thank you for taking us through the basic principles and then explaining how each tonometer helps, and also in explaining the current trends in the same. Thanks a lot. Next, with tonometry and gonioscopy covered, let's widen our horizon with newer trends in perimetry. Dr. John Davis Akra is a renowned glaucoma, cataract, and anterior segment surgeon at Western Eye Hospital and Chaitanya Eye Hospital, Kochi. He has trained at JIPMA, Arvind Eye Hospital, and Shankar Netralaya, and has 8 years of experience. He also has several publications to his name from Index national and international journals. Let's hear from him the latest and the best in perimetry. To you, sir.
Thank you, ma'am. I would like to thank Dr. Elizabeth ma'am and Dr. Girija ma'am for giving me this opportunity to present in a Little Flower. I was there for quite some time. I'm going to present on newer perimetry techniques. Is my screen visible?
Yes, sir.
Okay. So I'm going to talk about newer perimetry techniques. I'm Dr. John Davis Akra, and as ma'am mentioned, I'm in Western Eye Hospital and Chaitanya Eye Hospital, Kochi. Financial disclosure, I was involved in early prototyping and clinical mentoring of virtual reality visual field testing and has clinical and financial interest in the same. First, let us all know that standard automated perimetry is the cornerstone of glaucoma diagnosis and monitoring, and it is the most widely used method to monitor visual field in glaucoma. But the technology which we have been using is very old. It is old 1970s technology. The old machine was a very large machine with a resistive touchscreen, old CRT monitor, floppy drive, which has now been replaced with a pen drive. It is a very time-consuming and difficult to perform test and has often unreliable reports. So there has been a lot of evolution in the techniques and the devices and the algorithms. So first, I would like to thank Dr. Vaibhav Khanna, Anna June, Kanika Chabra and Dr. Vishwanath for this article, excellent article in Delhi Journal of Ophthalmology covering these things. So there is a lot of evolution in the algorithms. One thing is which we know is the adaptive mode, that is the staircase or bracketing, in which the brightness of the stimulus changes in steps of 4, 2, and 1. But that is an older strategy. Then there is a dynamic strategy in which the step size increases when the field effect increases. Then we know fastback, it is faster because it uses only steps of 3. Then the Swedish interactive thresholding algorithm, the CETA standard, was the one which was earlier used, which was replaced by the CETA fast, which takes less time but gives similar results. And in 2019, the CETA faster has been released, which is much faster while giving the same reliability. Then there are other algorithms like the Zippy adaptive threshold algorithm, which is used in the Octopus, tendency-oriented perimetry, which tries to predict what will be the threshold at individual points so that it doesn't waste time. Then the German adaptive thresholding estimation, the adaptive staircase thresholding algorithm, the continuous light increment perimetry, the spark precision and spark quick algorithms. So I'm not going into the details of all these. Just know that there has been an improvement in the algorithms itself for standard automated perimetry. CETA faster is actually 50% faster than CETA standard, and it uses the same algorithm and normative data as CETA fast. And it does this by starting the testing closer to the expected threshold for that patient. It uses only one reversal of the brightness, and it doesn't use the blind spot and false negatives for the analysis. And it uses instead the gaze monitoring and false positives for maintaining the quality. So it is, if you see here, it is much faster than the CETA standard, and it also incorporates the 24-2C. I'll tell you about that later. So there are also advances in early field loss detection by variation in techniques. One which we all know is the short wavelength automated perimetry. Then there is a frequency doubling technology, the high pass resolution perimetry, the rare bit perimetry, motion perimetry, flicker defined form, pulsar perimetry, flicker perimetry, and the micro perimetry or the fundus perimetry. I'm going into the details of only a few of these. This article again has further details about all of them. The short wavelength automated perimetry is there in all the newer models of the Humphreys automated perimeter. It is basically the blue stimulus on yellow background. It uses a Goldman size 5 stimulus, which is 1.7 degrees diameter, with a blue stimulus of 440 nanometers for a duration of 200 milliseconds on a 100 candela per meter square yellow background. And it predicts the onset and location of future glaucomatous visual field effects, which will be detected much later, that is 3 to 5 years later on standard automated perimetry. So you get pre-perimetric detection of glaucoma basically. But it is more variable and more difficult to determine the progression because of the variability. It is affected by the cataract because the yellow light is blocked by the cataract. It is more difficult to perform, takes 15 to 20 minutes per eye, and it takes 2 to 3 minutes for the adaptation to the yellow light itself. Then there is a frequency doubling technology, which is based on the nonlinear M cell neuron subset, which is first involved in glaucoma. So the principle is that when there is a low spatial frequency sinusoidal grating, that is the dark and light white bars like this alternating, that is undergoes a temporal frequency flicker, this will result in an illusion of a frequency doubling. That is, it will appear as if they are half the thickness, and you'll see this grating. So it actually tolerates up to 6 diopters of refractive error, room illumination changes, and pupil size variability. So because of that, it is not as restrictive as a standard HFA. This instruction is also very simple. The patient has to look at a black dot in the center of the screen. This is a device, and press a button anytime this grating pattern is seen. And this is what a report looks like. So that is frequency doubling technology. Then there is high pass resolution perimetry, in which ring-shaped stimuli are presented on a computer screen, which are high pass filtered. That is, the sharp lines and the soft lines are adjusted accordingly, so that all the low spatial frequency information is removed. And this takes only 5 minutes to test, has excellent test reliability, and detects progression earlier. And this is a sample report. Then there is a flicker perimetry, which is based on the detection of rapidly flickering stimuli, which is dependent on the magnocellular mechanisms, which are affected early in glaucoma. So there is a temporal frequency of flicker, the time duration of the flicker is varied to determine the highest rate at which the flicker is detected. It is critical flicker fusion. And this is how the report looks like. Then there is motion perimetry, where again the M cells are involved in detection of direction of motion of small dots and line stimulus. So it is used to detect the minimum displacement of the dots required to detect movement. And that is also one technique. Then in the standard automated perimetry itself, we are used to 24-2 because it detects all the fields, all the points which are important, while making it faster than a 30-2. But we may miss the early macular damage seen in 10-2 and OCD. So 24-2C was introduced in 2019, which incorporates an additional 10 test points in the central 10 degrees of vision. And this helps to not miss the things which can be seen only in 10-2. So you can do 24-2, and it is integrated in CETA faster by default. And that 24-2C with the extra points in CETA faster is faster than the standard 24-2 in CETA standard. So test time is less actually. Then of course, one major problem which we had with patients on HFA was putting the correct refractive correction for their power. And often the lenses break or are missing. So there is this liquid trial lens which has been there in the newer models, in which you have this. We have this electronically controlled device which can adjust the refractive power of the lens which is placed there by using a liquid which changes the curvature of the interface. And this can change from -8 to +8 diopters in 0.25 diopter steps. And this is important because a 1 diopter refractive blur produces approximately 1 decibel depression in the hill of vision. So you get a wrong visual field because of refractive error, which is uncorrected. And astigmatism up to 2 diopters is not required to be corrected. It can be taken as a spherical equivalent. Then, of course, we have the portable perimeters, the newer devices in perimetry, which started from laptop, tablet, and now it is all virtual reality perimeters. So early perimeters, there was a laptop perimetry. One early one was, which is still there and free, is keepyoursight.org's Peristat, which was initially developed by Dr. Soncho Sean Ionchlev from Bulgaria. He is a serial innovator who has developed several things, including the metered dose eye drop releasers and several other things. Then there is the ice cream software, which is also available for the computer. But they are not very accurate and doesn't have any proper tracking. Then there is the tablet perimetry. There is a visual fields EC, which is available on the iPad for free. And actually the same Dr. George Kong, I believe, he has made it into a commercial version, the Melbourne Rapid Field, which is now available commercially, and it is seen in several conferences now. These are tablet based, so it has its limitations of tracking and all that. but it is cheaper and easier to do. Then, of course, there is the tablet with a clip-on eye tracker, which is actually an open source free software. And it uses an inexpensive device, and the clip-on is also inexpensive. And in this, unlike standard automated perimetry, eye movements are permitted because the eye is being tracked, and no button pressing or head restraint is required. Patient just has to follow the dot and respond. Then if you search for virtual reality visual fields, you can see that there is a lot of articles being published. 144 results in PubMed itself. If you look on Google Scholar, you will get even more. And there are several devices now. But I was involved in this early one, Periscreener at Arvind Eye Hospital. This was what we had developed there. It was a virtual reality headset, which is a low-cost one, in which you put a smartphone inside and connect to a clicker by Bluetooth. And we were able to get results similar to HFA. So that was one. And then the company has developed CFA, which is now changed to Intelligent Visual Field Analyzer. Then there is the VF2000 from PalmScan, then the Vivid Vision Virtual Reality Perimeter, the VR eCloud Perimeter, and all these devices. And this is the CFA, which was the later version. Then there is the ELISAR Visual Fields, and so on. This is one of the later versions. This is the later versions reports. And now commercially, these are the two major players. One is this Alpha Alias Remedio Intelligent Vision Analyzer, and there is a ELISAR Advanced Visual Analyzer. Both of these are virtual reality headsets with a Bluetooth and Wi-Fi connection to a tablet in the operator's hand, and the subject has a clicker in their hand, which you press when you see the thing. Both cost approximately 3.5 lakhs each, and there is eye tracking built in the advanced version. So the camera keeps track of where the patient is looking. If the patient is not looking at the correct stimulus at the correct center, it automatically pauses the test. So you don't have to worry about fixation loss. If fixation loss is there, the test will pause, and you don't have to redo the entire test. And of course, the reports are both similar to the Humphrey Visual Field Analyzer reports, because that is easier to compare. And so that is it about this. I'm not going to further details about the reports of these. There has been a lot of comparison studies and trials which have been done with Arvind Eye Hospital, Shroff's, and AIMS, Delhi, and other places, and Johns Hopkins also. And the results are very promising. And this is very portable and can be taken to the patient's house and being done, which is one part of what is called Uberization of eye care, where the tests and devices for patient examination are taken to the patient instead of patient traveling to the hospital all the time. And then another one is the brain-computer interface perimetry, which relieves one major problem which we have with perimetry, that is the patient has to respond appropriately when they see a stimulus. So this one, what it does is it has a bunch of electrodes on the back of the head, which will look for a steady state visual evoked potential in response to the visual field stimulation. So the patient doesn't have to do anything except look at the stimulus. If the stimulus is seen, the device automatically detects from the patient's brain that the stimulus is seen, so that the test is more subjective, more objective. The patient's subjective errors reduce. And so that is all that I want to comment on newer perimetries. I would like to thank all the institutions where I have learned, that is Jipmar, Arvind Eye Hospital, Shankar Nethralaya, Little Flower Hospital, Ramchandra Medical College, West Eye Hospital, and Chaitanya Eye Hospital. Thank you.
Thank you, sir. Thank you for the wonderful flash. Thank you for simplifying the newer perimetric techniques for us. Early virtual reality perimeters seem to hold a great promise for future, with the advantage of patient being able to take it home. And the brain-computer interface perimetry makes it all objective. So thank you for a wonderful class. Next, let's move on to the next talk in the diagnostic module on imaging techniques, boon or bane. How can we confirm there is a structural change? How do we image? Let's hear it from Dr. Manju Anu. She's currently working as consultant at Glaucoma Services, Giridhar Eye Hospital, Kochi. She completed her long-term fellowship in glaucoma from RIO Bangalore, following which she did a short-term observership in glaucoma from the famous Queensland Eye Institute, Brisbane. Let's hear from her on imaging modalities now.
Is my screen visible?
Yes, ma'am.
Okay, sorry, I'm not able to connect my video somehow, so I'll just proceed without the video.
Sure, ma'am.
Okay. Good morning, everyone. I would like to thank Girija Madam for giving me this opportunity. So I'll be talking on imaging techniques in glaucoma. What are the advantages? So the diagnosis of glaucoma depends on the measurement of intraocular pressure, then detection of the structural changes using slit-lamp biomicroscopy, optic disc photography, and imaging techniques, and identification of the functional damage using perimetry. So intraocular pressure alone is not an indicator of glaucoma, and it cannot be used in isolation to monitor progression. And coming to the perimetry, about 20 to 40% of the retinal ganglion cells have been lost before the field defects develop. And also the visual field testing is often variable and it may require a repeated testing. So the most crucial step in the early diagnosis of glaucoma and monitoring progression is the optic nerve head evaluation. Subjective optic disc evaluation with optic disc photography still remains the mainstay of every clinical practice. So coming to the disc photography, which is an imaging modality, we have monoscopic color fundus photography of the optic disc, red-free photography of the RNFL, and optic disc stereo photography, which helps to identify the contour of the neuroretinal rim. So the sensitivity of the disc photography varies from 65 to 77%, and the specificity varies from 58 to 98%. Again, this depends on observer's training, the photograph quality, descriptive criteria for diagnosis, and the disease stage. And also there is poor agreement even among experts in the interpretation of the photograph. However, with improved camera technology and incorporation of the artificial intelligence and deep learning, the photograph may have a better utility in future. So here comes the role of imaging technology. So as you all know, the disease has a structural damage which precedes the functional impairment. So the earliest change which occurs is the accelerated apoptosis of the retinal ganglion cells, which lead to ganglion cell loss, and which in turn lead to the retinal nerve fiber layer thinning. Later, the functional impairment occurs, which can be detected with the perimeters. So if we have, as the structural abnormality precedes the functional change, if we have an objective, quantitative, and reproducible imaging techniques, it will help in the early diagnosis and monitoring of the disease. So here the role of OCT comes in. So we have the imaging techniques, we have GDX, HRT, and OCT. However, currently the widely used imaging technology in glaucoma is OCT. So I'll be talking on OCT here today. So optical coherence tomography, it helps in the early diagnosis, monitoring the progression, and also it helps to quantify the structural damage. So we had earlier time domain OCT, then currently the spectral domain or Fourier domain OCT, and the recent one is swept source OCT. So in Fourier domain or spectral domain OCT, we have different machines from different manufacturers. However, each machine has different scan patterns, segmentation algorithm, and display outputs. So we cannot compare the printouts from different machines. So now we will look at the parameters which can be measured using OCT. One is peripapillary RNFL thickness, then ganglion cell complex, and then optic nerve head parameters. So numerous studies have demonstrated that this RNFL and the macular parameters are reproducible with spectral domain OCT, and they have high diagnostic sensitivity and specificity in differentiating between healthy and glaucomatous eyes. So quickly, we will just see the optic nerve head RNFL printouts and the macular ganglion cell analysis printout. So on the top, you will have the demographic characteristics of the patient and also the quality of the image. So this is the RNFL thickness map, which is the actual thickness of the RNFL. And then it is compared with the normative database and give the deviation map, which is color coded. You have the segmentation scans, so vertical and horizontal segmentation. So for the any artifacts or for any segmentation errors, before interpreting the report, you have to look at these images. You have the optic nerve head parameters here, then neuroretinal rim thickness, then Tisnit graph of the RNFL. RNFL thickness is also given as quadrant and clock over distribution. So in the ganglion cell analysis also, you have the thickness map, then the deviation map, which is given in the quadrant and quadrant wise distribution also. This is the segmentation scan. So now we will move on to the peripapillary RNFL thickness, which is widely used now in the OCT imaging. So literature says that for detection of the glaucomatous damage, the SD-OCT RNFL parameter sensitivities ranges from 60 to 98% and specificity ranges from 80 to 95%. And these RNFL thickness parameters helps to identify the glaucomatous damage in up to 35% of the eyes 4 years prior to the detectable visual field loss, and in about 19% of the eyes, it helps us to identify the damage 8 years prior to the visual field damage. And with the spectral domain OCT, the reproducibility of the parameters is excellent, and the global average RNFL thickness is most reproducible. And inferior and inferotemporal sector RNFL parameters are most predictive for the progression. And what are the top 3 RNFL progression patterns? We may have widening of the existing RNFL defect, or it may show deepening without a widening of the existing RNFL defect, or it can be a development of a new RNFL defect. So this, the peripapillary RNFL thickness, how it helps in the diagnosis and monitoring the progression. So in the asymptomatic stage or in the pre-perimetric stage, it helps us to identify the early glaucomatous damage. In the established disease, actually RNFL thickness correlates with the disc and field changes. So in the mild to moderate disease, if we can show the progressive thinning of the RNFL, it is useful to judge the progression of the disease. Sometimes it may even give the progression before the GPA of the field detects. So this is the progression analysis from the Cirrus OCT. So the initial 2 scans are taken as the baseline, and then the follow-up scans, it compares with the follow-up scans, and you will get both event and trend analysis. So in the event analysis, when there is a progression occurs, it gives a color-coded warning. So whether it is a likely progression or whether it is a possible progression. And if the number of scans are 5 or more, it gives a trend analysis. Trend analysis, you will get the average RNFL thickness each quadrant wise, like superior RNFL, inferior RNFL thickness. It also gives the cup to disc ratio and also the Tisnit graph asymmetry. And in addition to the plots, it also gives the actual actual thickness, which is again color coded. So it helps in the progression analysis as in the GPA by HFA, sometimes even before the field progression happens. So I told in the early to moderate glaucoma, it helps in the progression. However, in the advanced defect, the OCT doesn't have much role because the RNFL thickness measured with the OCT comprise the thickness of the axons of the retinal ganglion cells and also the thickness of the residual glial cells or blood vessels. So in the advanced stage, there is complete loss of the retinal ganglion cells. So the remaining thickness will be the RNFL residual glial cells and the blood vessels, so which will not be changing and which will not show a progressive thinning. So the average RNFL floor values range from 49.2 to 64.7 microns. So in the advanced disease, RNFL thickness has not much value, but you can use the macular GCC and optic nerve head parameters to evaluate the progression. So now we will move on to the optic nerve head parameters. We get average RNFL thickness, rim area, disc area, all this shown here. But all these parameters are based on the reference plane. And the determination of the reference plane's position is the most critical point for accurate calculation of the optic nerve head parameters. So recently, there are some parameters which are reference plane independent. In this, most widely used one is the minimum rim width. So how they calculate the minimum rim width is, the machine will identify the Brooks membrane opening and then it measures the shortest distance from the Brooks membrane opening to the internal limiting membrane. That is the Brooks membrane opening minimum rim width. It also gives as a Tisnit graph and also the quadrant-wise analysis, which is again color coded, and it will give whether it is within normal limits or abnormal. So this RNFL and the minimum rim width parameters have a comparable diagnostic power in pre-perimetric, early or moderate glaucoma. And in advanced disease, as I told you, ganglion cell complex is better than RNFL or minimum rim width. And minimum rim width parameter is especially useful than RNFL when there is tilted disc or early paracentral scotoma. So now we'll move on to the macular parameters. The retinal ganglion cell layer, which is the thickest in the perimacular region, and it is about 7 cells thick in the macula, and it contains more than 50% of the total retinal ganglion cells of the eye. So the changes in this layer are more likely to be pathological, and it is more sensitive than RNFL thickness parameters. So different machine takes different layers into consideration. Cirrus gives ganglion cell complex as GCL IPL thickness. OptoView gives RNFL plus GCL plus IPL thickness, and Spectralis gives total retinal thickness. As I mentioned earlier, average macular thickness is more sensitive than peripapillary RNFL for disease progression. And in pre-perimetric and mild to moderate glaucoma, all these GCC, RNFL, optic nerve are equally effective, except in myopia, tilted disc, peripapillary atrophy, distortion. In these cases, GCC plays a better role than the RNFL or minimum rim width. In advanced glaucoma, ganglion cell complex is better than the RNFL and the optic nerve head parameters, and GC-IPL is more distinguished than RNFL for detecting glaucoma in case of parafoveal loss, and it is well correlated with 10-2 standard automated perimetry. So patients with abnormal or borderline macular parameters, they require a close follow-up to assess the progression. And if there is a progression, they may need an initiation of therapy required. And however, the clinician should not rely entirely on the macular parameters because the ganglion cell thickness can also be affected by other macular diseases. So now we'll see what are the limitations of the OCT. So it has many artifacts. Sometimes the decentration of the calculation circle or PVD or posterior and anterior RNFL misidentification, if the poor signal strength, all these can cause false readings or false diagnosis of the glaucoma in if you consider only the OCT. Also, the macular conditions can affect the ganglion cell complex scan. And another disadvantage is the normative database. So the normative database include around 300 to 400 patients and between 15 to 78 years. So, and also they will not have the normative database for extreme refractive errors, young children and people from different races. So if the values are outside the normative database, it will be red flagged. So this should be keep in mind while interpreting the OCT scan when the patients comes into this criteria. So now, what is red disease? Red disease occurs when the OCT mistakenly identifies as abnormal when actually there is no disease. So this happens when, as I told you, when there is a limited normative database and then pathologies other than glaucoma, all these can cause red disease. And what is green disease? Green disease occurs when an OCT data shows no signs of abnormality in presence of a disease. So here in this scan, if you see that actually the OCT scan is identified as normal, but if you look at the dip here, it may be an early glaucomatous damage, which is not identified if you look at the quadrant or clockwise distribution. Other conditions which can lead to green disease include optic nerve head drusen, PVD or myelinated nerve fiber layer, papilledema or pseudopapilledema, where you miss the glaucomatous RNFL loss because of the pseudo increase in the RNFL thickness. So the recent swept source OCT helps to image the choroid and the lamina cribrosa in addition to the RNFL and the macula. So this lamina cribrosa, you can see the posterior displacement of the lamina cribrosa and the lamina cribrosa pose with the source OCT because of the enhanced depth imaging. So these changes actually happens even before the RNFL thickness, RNFL loss happens. So it may help even prior to the RNFL imaging. It may help to identify the pathology. So OCT angiography, it's a repeatable high resolution quantitative evaluation of the retinal vascular abnormalities in vivo. The reduced retinal perfusion in the superficial vascular plexus is observed in glaucomatous eyes, but whether this reduced ocular blood flow is a cause or the result of glaucoma progression remains unresolved. These are the OCT angiography pictures. So now we'll move on to the anterior segment imaging, mainly ASOCT and UBM. Anterior segment imaging is the direct in vivo evaluation of the anterior segment. It gives cross-sectional image of the anterior ocular structures. So ASOCT is a non-contact method for screening and progression of angle closure. Now we'll see what are the advantages over the gonioscopy, which is the gold standard. So ASOCT helps in the quantification of the angle. This helps to evaluate the anterior chamber changes following the interventions such as laser iridotomy and iridoplasty. Also, it gives anterior chamber quantification of the anterior chamber parameters like an anterior chamber depth, anterior chamber area, iris parameters like iris thickness, and also lens parameters like lens thickness and lens vault. Recently, this lens vault is emerging as a potential new risk factor for angle closure. So how you measure the lens vault? So you have to identify the anterior pole of the lens and then identify the scleral spur and draw a horizontal line between the scleral spur and a perpendicular line joining the anterior pole to the horizontal line connecting the scleral spur is the lens vault. So it is identified as a new risk factor for angle closure if the lens vault is more. So ASOCT also helps to assess the bleb morphology. Where is a normal filtering bleb with microcyst, or it is an encapsulated bleb or scarred bleb. And also in case of glaucoma, drainage device to identify the position, patency, and whether there is any intraluminal deposits or suture or any tube corneal touch or tube iris touch. This is the cross-sectional image which is showing the tube here. Here it is okay, but here there is a corneal touch. Now moving on to UBM. UBM also helps in the quantification of the angle parameters, lens, vault. In addition to this, it also helps in the diagnosis of the Plato iris. The another advantage over ASOCT is we can evaluate the structures behind the iris, like iris cyst, ciliary body mass, or ciliochoroidal effusion, which can cause a secondary angle closure where the management is completely different than the primary angle closure. So these are the comparison between UBM and ASOCT. So the newer anterior chamber anterior segment imaging methods include pentacam, scanning peripheral anterior chamber depth analyzer, and goniophotography. So now a word about the role of artificial intelligence. Now the artificial intelligence is incorporated in fundus photography, OCT, and gonio-photographs. So this gives extremely high accuracy when compared to human graders, but we need more studies on this. So to summarize, the technological improvements in imaging improves the glaucoma diagnosis and monitoring. And currently, the imaging technology complements the clinical evaluation. Maybe in future, the integration of AI, deep learning, machine learning, and big data may help to identify the gray zones of the diagnostic dilemma or provide information for the prognostic survey and contribute to information for unknown points in pathogenesis. But at present, detailed clinical evaluation, gonioscopy, and perimetry still remains the gold standard in the diagnosis and management of glaucoma. Thank you.
Thank you, ma'am, for a very extensive class on various imaging modalities and how you explained the lamina cribrosa position, swept source OCT, and the lens vault assessment in ASOCT for angle closure. And as you said, the imaging for the time being complements with the clinical evaluation. Thank you for the class.
Dr. Manju's presentation on OCT was really informative. Actually, the newer developments in imaging might be a very helpful tool for glaucoma diagnosis in future, with the incorporation of artificial intelligence and all those other helpful software. We may be able to diagnose more early diagnosis of glaucoma. And I think we are running ahead of time. And shall we proceed to the next session? Dr. Arup sir, are you ready?
Yeah.
Then okay, then I think we'll proceed to the next session. That is the treatment modalities. Over to Danya.
Moving on to the treatment module, which is divided into medical and surgical modalities. Glaucoma is mostly managed medically in the initial stages, but how do we manage the special scenarios and what are the newer trends in the game? Let's welcome Dr. Arup Chakrabarti, a stalwart in ophthalmology. Welcome again, sir. Dr. Arup Chakrabarti is a senior consultant and director of Chakrabarti Eye Care Center, Trivandrum. His field of interest has always been complex cataract surgery and glaucoma. He's a multifaceted personality with academic awards and recognition from various national and international organizations, including Achievement Award AAO and BPOS at ASCRS meeting 2009. He has been elected as the member to the highly prestigious and exclusive International Intraocular Implant Club 2015. He is the current editor proceedings for AIOS, Editorial Committee IGO, President KSOS, Member Scientific Committee AIOS for 2008-2014 chapter. Apart from this, he's also a very passionate teacher with being the chief instructor for more than 200 instruction courses and has edited 3 books on cataract surgery. We're ardently waiting to listen to your class, sir, on medical management and the current trends.
Good morning, friends. Can you see my slides?
Yes, sir.
Yeah, I'm audible too. That is okay. So thank you, Dr. Dhanya, for the very kind introduction. And thank you, Dr. Girija, for planning such a meticulous program. And congratulations to Little Flower Hospital to coordinate, to help you coordinate the whole CME program. I have been asked to talk on medical management of open-angle glaucoma, newer horizons, and special scenarios. So I will talk in the reverse order, and I'll first talk to you about the special scenarios and start off with medical management of glaucoma in pregnant and breastfeeding patients. Now, glaucoma is a disease of the elderly. On the other hand, pregnancy and lactating mothers are usually on the lower age group, though the scenario is changing. So how do we solve this dilemma? Actually, this questionnaire was shared with the British ophthalmologists, and the survey was performed, and the results were published in 2007, which basically addressed more of the issues which we really need to know while managing these cases. The results were quite interesting. More than 1/4 of the surveyed doctors had previously encountered this scenario in their practice. And unfortunately, more than 1/3 of these doctors were not sure about what treatment option they would choose. And there are a lot of other interesting findings in this particular article. But it concluded that there is a general level of uncertainty among ophthalmologists about this situation. And it recommended that there has to be consensus guidelines which have to evolve depending upon future evidence-based research. So what exactly is the challenge? These mothers are on anti-glaucoma medications which go to the plasma, and then they may cause the blood placenta barrier and result in teratogenicity and phytotoxicity for the fetus. So many a time, a mother may either become non-compliant, or we really have to decide as to what exactly is to be done to manage this patient. So this is the challenge. And again, there was a special commentary published in the Ophthalmology Journal, a practical guide to the pregnant and breastfeeding patient with glaucoma. So whenever we consider any medication for a pregnant patient, we need to refer to these FDA drug risk categories in pregnancy. This was established in 1979, this 5-letter system for categorization of patients for the different drugs for the risk category. And this is valid only for drugs which were released, which are approved till June 30, 2001. Medications which came later on, there is another system to categorize them. So basically, category A means, these medicines are the safest, and well-controlled studies in pregnant women have not shown an increased risk of fetal abnormalities. On the other hand, as you go down to group category E, there is evidence of fetal abnormalities in the well-controlled studies in animals or humans. So they are absolutely contraindicated in pregnancy. So all the glaucoma medications that we use, most of them belong to category C, and it's only brimonidine which belongs to category B. If you see the GSA guidelines which were released sometime back, it basically tells you about the individual medications and their teratogenicity, their adverse effects on the fetus, etc. So please refer to that. Now, looking into what we should be doing. Now, if we have a patient who is on glaucoma medications, and we have to decide which medication to choose, I think in the first and second week of the second trimester of the pregnancy, brimonidine is a drug which belongs to category B. Apraclonidine is no longer available here. So beta blockers could be used in the first and second trimester. We try to avoid it during closer to the delivery because of its neonatal effects. Prostaglandin analogues, again, are a good medication to go to. They should be used only at the third and possibly second because of the risk of early labor. They can induce uterine contractions. The newer prostaglandins, they like Vizult, etc., they should not be used. Carbonic anhydrase inhibitors, again, they belong to category C, and they can be used in late second and early third trimester of pregnancy. Rho kinase inhibitor, again, it doesn't belong to any category, so it's better to withhold these medications. Now, after having tided over the pregnancy, Now, the lactating mother or the breastfeeding mother, brimonidine, which was indicated for the during pregnancy, is contraindicated because we know that it is capable of CNS depression, apnea, lethargy, and bradycardia in the child, in the infant. Beta blockers can be used safely, but we need to exercise utmost caution in infants with cardiopulmonary disease. Prostaglandin analogues other than Vyzulta, and I'll be talking about these medications later on, are likely safe. They have a very short half-life. Carbonic anhydrase inhibitors are also safe. Pilocarpine, the long-term effects are not really known. And again, the rho kinase inhibitors, there is no data available. Now, if it comes to that situation where the intraocular pressure is not controlled, the mother's glaucoma is going up, the damage to the structure and function is continuing, we may consider selective laser trabeculoplasty, which may eliminate the medication burden. If not, it may decrease the medication burden. But remember that it requires an open angle and it is less effective in these younger patients. In certain situations, surgery have to be considered, avoiding the first trimester. Surgical, there are challenges because these are young patients. There's increased risk of failure, more fibrosis in these patients. What anesthesia, preferably it has to be topical anesthesia. Then the question about the postoperative antibiotics, anti-inflammatory drops again crop up. And it may be difficult for a patient, a pregnant patient, to lie in a supine position without any hypotony for a long period of time. So basically, in summary, we need to talk to the patient even before the patient has considered the pregnancy. There has to be a detailed discussion about the treatment goals, what are the target IOP, what are the treatment options, depending upon the categories that I've mentioned, and the treatment strategy. Because sometimes in a pregnancy, the intraocular pressure goes down by about 1 or 4 millimeters of mercury. Sometimes because it is a limited period of time, a couple of months, so we may succeed in stopping therapy, at the same time monitoring for glaucoma progression in the mother. So basically, all these discussions should be held with the patient, with the family, and the entire healthcare team, including the obstetrician, the pediatrician, and whoever is part of the team. So pregnancy, I just mentioned, might alter the course of glaucoma. So a tailored close follow-up is recommended. Before pregnancy itself, we should be able to identify the drops which can be safely administered and have a plan of action, whether the patient will require SLT or patient can continue with pregnancy without much interference from our side. And whenever drops are used, they have to be used with nasolacrimal occlusion and lead occlusion. Particularly for a nursing mother, it should be used immediately after the breastfeeding is over, not before that. Glaucoma surgery is rarely indicated, and and sometimes when the patients ask about what could be done to mitigate or to avoid the worsening of glaucoma in them. There is nothing they need to do, like for example, sleeping position, delivery method of choice are unlikely to cause any clinically meaningful intraocular pressure increase. So this is about managing a patient, the glaucoma patient in a pregnancy when she is breastfeeding. And next we move on to the pediatric age. We all agree that it is basic pediatric glaucoma is a surgical disease, and it is the mainstay of the treatment. Surgery is the mainstay of the treatment for these young people. However, medications also have been found to be very useful, both as a long-term measure or a temporary measure. These are all the indications that are mentioned here. Now, there was the big study, a British infantile and glaucoma study, which was published in IVS in September 2007, which emphasized that medical treatment definitely has to be should not be relegated to the background. It will be useful in many situations. For example, 71% of the patients with primary surgery without a full IOP, without hitting at the target IOP, will receive intraocular pressure, receive anti-glaucoma medications during the first 1 year follow-up. And the percentage of patients where the treatment has been started, percent of the partially successful surgery patient where treatment with anti-glaucoma medication has been started increases from 60% to 94%. So that is a significant number. Then medications can be used preoperatively to control IOP or in between two surgeries. And sometimes when the patient is a poor surgical risk, it is the only option. Now, as opposed to the adult glaucoma, we don't have, we need to have an evidence-based consensus guidelines to have, a treatment strategy for the pediatric age group. Now, in adult glaucoma, this subject has been well studied, and there are two meta-analyses. One included 28 RCTs of glaucoma monotherapy, another one 41 RCTs. So we basically have a good evidence-based approach, which is lacking in the pediatric age group. So this particular article, Graph is Clinical Ophthalmology, it looked into it, and it is easy to understand why so much of literature is lacking in this particular field, because pediatric glaucoma is not a common situation. So the evidences are meager. There are ethical concerns while trying to conduct a RCT on these young people. And then it is a very time-consuming and infrastructure requiring, workup. So that is the reason only there are only 5, RCTs, that also not very well-planned RCTs where they're available in the literature. I'll not go into the details, but what I'd like to tell you that, say, these RCTs basically have a consensus that, the effectivity of the pressure lowering effectivity of the medications are similar to the adult population. The percentage of responders are significantly reduced as opposed to the adults in children. There are safety concerns because the serum concentration builds up to a higher level than the adults, because there is reduced volume of plasma, and because the concentration of the principal plasma binding, reduced concentration of the principal plasma binding proteins in these young patients. For example, with respect to timolol, intravenous administration and ocular administration gives almost the same plasma level. And children receiving 0.25% of timolol can achieve a higher plasma concentration compared to adults who are receiving 0.5% timolol. Prostaglandin analogues again have a very good safety profile. So again, looking at these 5 RCTs, we see that timolol had about 25% pressure lowering efficiency. On the other hand, the prostaglandin analogues did better. Latanoprost and travoprost, they did better. So in the light of the potential systemic side effects, it is important to minimize the absorption of the drug, especially when using beta blockers. So use the lowest concentration, preferably use a gel formation, and use lacrimal punctal occlusion. And prostaglandins have become the most commonly prescribed monotherapy for the management of childhood glaucoma. While using prostaglandins in aphakic patients, of course, the controversy stays whether whether macular edema occurs or not. But then, it has, if the patient is well controlled with PGAs, my go-to medication will be a prostaglandin analog to control the intraocular pressure. While beta blockers, it is best avoided in premature and small infants. It is a good idea to use 0.25% timolol, and epitaxolol actually has a better systemic adverse effect profile, but does not lower the intraocular pressure that much. Carbonic anhydrase inhibitors are the first or second line therapy in young children. Dorzolamide 2% or brinzolamide 1% 3 times a day. And severe adverse effects like metabolic acidosis are not very commonly seen for topical therapy. Oral or IV therapy is not approved for use in children, though of course there could be an off-label use. Again, coming back to the alpha-2 agonist brimonidine, it should not be used in infants and children less than 7 years and with weight less than 20 kilograms. So friends, it is also very important that after initiating the therapy, the patient has to be monitored properly. So the general examination becomes very important. We need to look into the patient's vital signs and patient alertness, particularly the patient on beta blockers. And sometimes we need to have a good feedback from the parents or the family members and report and actively look for these adverse experiences that the child might go through. And then sometimes it may be useful or it may be necessary to monitor the patient's care along with an experienced clinician and to find out whether the problems, the adverse effects are due to the eye drops, and then decide whether the eye drop should be continued or we should change into a different eye drop. And of course, the ocular examination should continue. And for us to evaluate the patient properly, measure the intraocular pressure, look at the optic nerve vein, examination under anesthesia may be required. So this brings me to the end of this talk. And now.
Thank you, Dr. Arup, for that very informative presentation. It's actually a very vast topic which you have made and presented in a very concise manner leaving no areas untouched. Actually, these special situations are a treatment dilemma for all the practicing ophthalmologists. And that's why I wanted to have the topic in this session, and I wanted an expert to talk on that. So thank you, sir, for presenting this topic. And it was very informative. Actually, the pregnancy and lactation and children, that's always a dilemma. And which drug to give is always, we are always confused. As you said, all the ophthalmologists are confused in that it's actually a gray area. And this lecture was very helpful. And thanks a lot, sir.
Thank you, Dr. Girija. So is the time for me to go to the second part of the talk?
Yes, sir.
Okay. So now the second part is actually the medical management of open angle glaucoma, the newer horizons. And this is based basically on the contents of a review article that our team published in the IGO in June 2022 issue, as well as other research that went into generating these contents. I have, since I'll be talking about certain products, so I have no financial interest in any aspect of my presentation, but there is a disclaimer. Most of the topics that I'll be talking about, I have no first-hand experience, other than some of the, the medications which have come into the Indian market. So this talk was basically built by looking at the references and my personal interactions with the glaucomologists in the Western world about what their current views are. And I tried to also contact the principal investigators to the extent that it was possible. Now, this is basically, the various new glaucoma medications are at various stages of development. Now, since it is a vast topic, it may not be possible for me to deal with each and every aspect of it. So I just would like to impress upon you that please use this as a triggering opportunity, as a triggering event for you to develop interest in what all new things are happening in the field of medical management of glaucoma and take it forward from here on. So my focus will be on those products which are in clinical use right now, and some of the other products which are nearing clinical trials and the completion of the phase 3 trials and are about to receive FDA approval or other relevant approvals. So we all agree that in spite of selective laser trabeculoplasty and the popularity of MIGS, medical management is the mainstay in most forms of glaucoma, in the management, most forms of primary open angle glaucoma. We still, the holy grail is the ideal glaucoma drug with all these attributes. We are not there. And the journey began actually in 1875 with pilocarpine. 100 years down the line, timolol came into this scenario. 1996, we had latanoprost. And then last couple of years, 4 or 5 years, we have seen a sort of renaissance. A lot of interesting molecules have come to the market. So again, I'll be talking about what are the newer molecules, and then what are the new combinations that are available, and the newer drug delivery system. There are 2 new molecules that have come up, the ROCK inhibitors and the nitric oxide donating drugs. There are a variety of nitric oxide donating drugs, and those in development are, one nitric oxide donating Bimatoprust, nitric oxide donating drugs without any incorporated prostaglandin, nitric oxide donating dorzolamide, and nitric oxide donating benzolamide. But what is being used is a nitric oxide donating beta blocker, which is being used in Japan, not yet FDA approved. And then which a couple of years back, a drug which received FDA approval was a nitric oxide donating latanoprost and Benod 0.024%. So this is the complex chemical structure, and this is a prodrug, and that is hydrolyzed by the corneal hysteresis into the active components, latanoprost acid and nitric oxide. You must be familiar with the mechanism of action.
Sorry for interrupting, sir.
Yeah.
Is there a share screening? Just remind me.
To see?
No, sir, not yet.
No slides, is it?
Slides, we can see your previous slides, but not the current one.
Okay, I'll do it again then.
Yeah, thank you.
You should have told me earlier. Is it visible now?
Yes, sir, it's visible now.
Yeah. So basically, and this is where we had started from. Yeah. Just briefly go through. Yeah. So basically, I'm going to elaborate more on latanoprost and Binod among the nitric oxide donating moieties. This is hydrolyzed into latanoprost acid and nitric oxide, which are the active moieties. And latanoprost and Binod belongs to the prostanoid group of prostaglandins and hypertensive liquids. Now, there are two modes of activities. The latanoprost acid basically increases the aqueous flow through the UV scleral, the non-conventional pathway, by bringing about extracellular matrix remodeling and working through the matrix metalloproteinase 1, 3, and 9. We are already familiar with that. But then it is the nitric oxide component, which is new here. It is interesting to know that nitric oxide was the molecule of the year in 1992. And in 1998, the Nobel Prize for Physiology and Medicine was given to a work done on nitric oxide signaling for cardiovascular system and cardiovascular diseases. So basically what it does is it brings about a relaxation of the trabecular meshwork cells, and then there are cytoskeletal rearrangement, reduced cell adhesion, reduced cell contractility, reduced cell volume. And then all these mechanisms act together to increase flow through the trabecular, enhance flow through the trabecular pathway, conventional pathway. It is also a potent vasodilator, so it vasodilates the ocular blood vessels. Very interesting and landmark studies and very interesting studies were performed. I'll just tell you the results. This has been a very, very effective pressure lowering moiety. It was found that it was non-inferior to timolol in both the Apollo and the Lunar, their phase 3 studies. If you see the quantum of intraocular pressure drop, in the Apollo study, it was 9.1 at, let's say, week 6 at 8 a.m. And the minimum pressure drop was seen on week 2 when the treatment was just started in the evening, 7.5. And it was always more than the pressure drop brought about by timolol. Again, the mean IOP reduction was 32% across both the studies. And if you see that difference here from the mean IOP, the blue curve that you see here is the latanoprost and Binod. So, and it worked extremely well. And there is an extension period of 1 year for both the studies. And the effects of these medications lasted for 1 year. And for 1 year, the medications were effective. As regards the adverse events, the immediate adverse events were more compared to timolol, but only 1% of the patients treated with latanoprost dropped out of the Apollo and Lunar clinical studies. And regarding other side effects, because there is already a prostaglandin moiety within the molecule, so we can expect the other complications of prostaglandin. As regards the contraindication, the concentration, LBN is 0.024%, which is more effective in pressure lowering compared to a higher concentration of LBN. And we know for latanoprost, it is, it is basically an optimal concentration that is responsible for bringing down the pressure down. And it was again, more effective than latanoprost in overall IOP reduction. So again, there was a meta-analysis which compared latanoprost and Binod to latanoprost, travoprost, Bimatoprust 0.1%, and it was found that the LBN numerically outranked all the other 3 prostaglandin analogues. I have already discussed its role in pregnancy. It is in category C. No data on the presence of LBN in human milk, and it should not be used in children less than 16 years. So other drug that has come up and it is available in our country is the Rho kinase inhibitor. This is an interesting drug because it is one of those drugs which are emerging, which are known to enhance the trabecular outflow component. So basically the 3 categories, the ROCK inhibitors, AR12286, which is basically ripasodil, then adenosine A1 receptor agonist, and ROCK-NET inhibitor, which is netarsudil. So fortunately, there are 2 companies that have come up in our country, and I think another company is coming up, where netarsudil is available and ripasodil is also available. Now, how does it work? Basically, again, netarsudil acts by inhibiting the Rho kinase. It relaxes the trabecular. There are a lot of downstream effects, and finally, we find that there is relaxation of the trabecular meshwork, clearing of the extracellular matrix, increase the drainage of aqueous humor outflow, and which all results in reduction of intraocular pressure. In addition to this activity, the Netarsudil has the ability to reduce episcleral venous pressure, which dilates the episcleral veins, reducing the intraocular pressure further. And through the norepinephrine transporter inhibition, it also reduces aqueous production. Rpc has additional benefits in addition to pressure lowering, neuroprotection, increased ocular blood flow, potential to reduce scarring after glaucoma surgery, preserves corneal endothelium, protective effect in diabetic retinopathy and macular edema, etc. Rpc is used 2 times a day and it need not be refrigerated, and so it is not as effective as Netarsudil. So the Netarsudil basically have been evaluated by the Rocket studies, Rocket 1, Rocket 2, and Rocket 4. And this is where you see it is a pooled study results. This is the baseline, and then there is a significant drop in the diurnal pressure after Netarsudil treatment was started. And it is maximally effective if the baseline pressure is less than 25 millimeters of mercury. If you see here, percentage of patient, the blue vertical bar, the percentage of patients achieving more than 20% IOP drop was more till a cutoff value of 25 millimeters of mercury. Anything more than that, Netarsudil was less effective than timolol. Another way of looking at it is, regardless of the baseline intraocular pressure, Netarsudil was responsible for a 4 millimeter mercury pressure drop. On the other hand, with timolol, it was higher the baseline pressure, more was the intraocular pressure drop. And again, Netarsudil worked well for more than a year. There were hardly any systemic side effects. The topical side effects included conjunctival hyperemia, corneal verticillata, which went away after stopping the medications, and small microhemorrhages, again, which near the limbal area, which dissipate on its own. So next interesting drop, and for which again we have it has not come to the Indian market, is a combination product, combination of Netarsudil and latanoprost. It was approved by FDA in 2019, and it is again an evening once a day dosing. So while looking at it, it looked as if it was the most effective pressure lowering medication, because it works by increasing UV scleral outflow, increasing trabecular outflow, reduces aqueous humor production, and reduces episcleral venous pressure. So all modalities of pressure reduction are made use of by this particular molecule. And again, if you compare, this is what you see below is the Netarsudil pressure drop, the intraocular pressure. So compared to Netarsudil alone or latanoprost alone, compared to Netarsudil alone or latanoprost alone, the combination drug had a far greater pressure lowering effect, both Mercury 1, what we saw here, and the Mercury 2 studies. And again, it was effective, more effective than the individual components when you set up a target pressure, whatever it was, 14 millimeters or 18 millimeters. This is the blue vertical bar. So there is a higher percentage of patients achieving the target intraocular pressure. There's a higher percentage of patients achieving, the pressure drop after initiating surgery with the Netarsudil latanoprost fixed dose combination. The side effects again are to be expected, because Netarsudil is there, congenital hyperemia, corneal verticillata, and so these have to be kept in our mind. Now moving on to the new drug delivery system. In cataract surgery, we have already been familiar with Dexis-U and Dextenza, and now this is also coming up in the field of glaucoma. The punctal plug delivery system is used by the Travoprost punctum plugs, which is an investigational device. This is basically a drug-eluting core within a proprietary plug. So this has been phase 2 studies are going on, and the major concern has been the retention of the plugs. So it has been found to be pretty effective in terms of pressure lowering when compared to the timolol group. The Bimatoprust sustained release ring, this particular DocuSert, which has started with pilocarpine a couple of decades ago, were given up, but this appeared to be a little promising. This particular ream is kept in the conjunctival fornices. It has a 13 milligram of Bimatoprust, which is impregnated, and it dilutes the drug over a period of time. So it is quite effective. When I contacted Dr. Brand about the phase 3 trial, its status, I could not get any response from him. So I'm not really sure what exactly is the future of this particular beam insert. This is another medication which has got an FDA approval. This is the Bimatoprust implant. It is a 1 milligram device containing either 10 or 15 microgram of Bimatoprust. And so this is injected intracamerally, and it stays inside the anterior chamber and elutes the medication. So that the trials, phase 1, phase 2 trials have shown that this medication was doing pretty well. But subsequently, when repeated injections were made in the subsequent trials, it was found that it was associated with corneal decompensation. So some of these things had to be removed. So one has to be careful while dealing with these implants. Then next is the iDose travoprost. This is basically from glucose. Again, it is injected into the angle, and then it elutes the travoprost. These have been found to be pretty comparable with timolol in terms of intraocular pressure lowering, but it brings about a greater pressure lowering compared to timolol. There has been no intraoperative adverse events, and plasma levels also have been very low. So Omnidopac isopropyl, again, it is a selective non-PG prostanoid. This is available in Japan, and it increases the UV scleral outflow. The advantage of this is it is a particular benefit for treatment of patients with concurrent cystoid macular edema. So basically, friends, in conclusion, I would like to say that there are a lot of drugs which are having a preclinical trial. For example, the small interference RNA, gene therapy, stem cell therapy, alpha lipoic acid. Some of the ongoing trials, cannabinoids have been used, but so results have been not very encouraging. These are the medications and clinical use, and those who have used it have found these medications pretty useful in the West. There is, of course, they are not usually the first line product. They are usually used, as an add-on, and they definitely have been found to be quite beneficial. Thank you very much for your kind attention.
Thank you, sir. Actually, these newer drugs have revived hope among the advanced and refractory glaucoma cases, where we have finished with all the available drugs, and now that this Ripasudil, Netasudil, everything has become available, at least some hope that we can give to the patients. So thank you very much, sir, for giving us a very detailed account of the newer drugs. Actually, it was very informative.
Thank you.
Thank you, sir. Dr. Danya?
Yes, ma'am. We were to have a class on role of newer lasers in POAG by Dr. Rajul Parekh, but unfortunately, due to an emergency, he can't be with us today. Our apologies for the same. So let's now move on to the surgical modalities. A trabeculectomy is the most commonly performed filtering surgery with the best outcome in glaucoma. But how do we manage a failed trabeculectomy? Trabeculectomy, the gold standard, and management of failed trabeculectomy. Let's hear it from Dr. Ganesh Venkataraman. He is the Chief Consultant in Glaucoma Service in Arvind Eye Hospital, Coimbatore. He is a glaucoma specialist with over 15 years of experience and has contributed to numerous clinical drug trials for approval by Indian Regulatory Authority, DGCA, and USFDA. He has also been part of the Indian Family Angle Closure Evaluation Study too, which itself has contributed to approximately 10 publications in international literature. He received the Young Ophthalmologist Travel Grant Award during the World Glaucoma Congress, Vancouver in 2013. Over to you, sir.
Thank you, madam. Thank you for the introduction. I would, at the outset, as I'm sharing my screen, like to thank Dr. Girija, Little Flower Eye Hospital, and KSOS for providing me this opportunity to speak to you on the topic given to me, which is trabeculectomy. I'll just adjust my screen a little bit. Is my screen visible?
Yes, sir.
Okay, I'll just hide the panel, floating panel. Right, okay. Thank you, madam. Thank you for the invitation. Thank you for the opportunity. I'll be speaking to you on trabeculectomy and how to manage a failed trab. So, as you all know, trab is the gold standard glaucoma surgery, and there's a lot of evidence to show that you have long-standing IOP reduction over many years, and notwithstanding the fact that it has a lot of complications also. And is it the ideal surgery? So ideal surgery is something which should be performed by all surgeons, which requires simple instrumentation with minimal complications, replicable technique with short learning curve, and economic with long-term success. But unfortunately, TRAB is not an ideal surgery, so it requires a lot of learning curve. And over many years, with variety of presentations with the patient come with, it's a challenge to get the successful results, as you may see in the image there. So coming to the anesthesia, straight to the point, one of the best anesthesia for TRAB will be general anesthesia. And you should be very careful with retrobulbar and bulbar anesthesia, mainly because of the possibility of retrobulbar hemorrhage in eyes which have the optic nerve, which is very compromised. So in our institute, we have shifted to subcutaneous anesthesia for all our patients, and we give it in the infranasal quadrant with a subcutaneous cannula. And it's working very well for us. And for patients with high risk and pediatric population, of course, you require general anesthesia. So whenever you are planning for either a repeat or a fresh trabeculotomy, always look at the conjunctiva. So better look at a conjunctiva which shows a little bit of mobility, as you can see in the video on the right side. Video on the left side is a patient who has undergone ECC a long time back, and you can see that this mobile conjunctiva is not at all mobile. So this is something which you have to practice, especially if you are planning for a repeat TRAB. And exposure, as you come to the surgery per se, exposure is obtained either by a good quality lid speculum, which we use the Castrovicius lid speculum, which is self-retaining, and at the same time it lifts the lids above the globe, so the lid pressure doesn't apply to the globe as the patient squeezes, if at all that happens. And we also use preferably to use a corneal traction suture or a superior rectus brittle suture. Brittle suture we use with a 4-0 sil suture with a round body needle, or corneal traction suture we use a 7-0 or a 8-0 polygalactin suture, which is done under visualization. So it's not done blindly, and you take a crisp bite on the cornea. Conjunctival incision is, we practice fornix-based surgery unless it's for pediatric population, where we do a limbus-based TRAB. So the incision is slightly larger if you're planning for a combined procedure, like SICS TRAB. But for a TRAB, you can have a 5mm peritomy. Preferably cut the tenons and conch together and undermine the conjunctiva so that you can pull forward the conjunctiva and make sure that the flap region is nicely put. Once you have, be very careful as you're disinfecting the conjunctiva. Use serrated forceps preferably for holding the conjunctiva, and you can always undermine on either side. The episcleral tissue should be removed. Gentle cautery is sufficient to obtain hemostasis. Use the tenons beneath the conjunctiva to retract the conch and do the cautery. We usually prefer to use the eraser cautery. You could also use the forceps cautery for this particular step. Please avoid always thin scleral flap. In the first initial part of the training, you will have a tendency to have very thin scleral flap. The trick is to measure, to get the, we use a 15-number Barden-Parker knife. So the 15-number Barden-Parker knife has a 1mm bevel. So as you give a scratch incision or a groove on the sclera, you find that the 50% of the blade is in the sclera, which gives you a good indication that you have achieved a 50% depth. So that should be give you a good indication that you can see that this is a 1mm bevel of the Barden-Parker knife. And as you make the groove, you find that 50% of it will be stained by blood from the sclera as it passes into the groove. So once you keep the blade in the groove and you tilt it, you'll find that you can see 50% of the blade which is visible. The rest 50% will be in the depth of the groove. So once you lift a scleral flap, be very wary of a thin scleral flap. Always have your assistant mop the area so that you see a little better. As you can see, there's a thin scleral flap being lifted, and then you are deepening the incision and going slightly deeper. So avoid a thin scleral flap, which should be at least 50% depth. Scleral flap can be of any shape or size. The main attribute should be that they should be of a sharp edges. They should not be undermining, and they should be partial thickness, and the outline should be cut with a single pass. The corner of the flap is raised with a blade, and we usually prefer to apply MMC before dissecting the scleral flap. So as you pass the blade, you can see that it is 50% depth. And after this, we apply the mitomycin C. Slightly lift the flap with the tip of the blade like this. Mitomycin C, we use 0.2 milligram per deciliter. So how do we prepare it is, just to show you a small video. It comes in 2 milligram in 2 cc vial. So we use 2 cc of water for injection into the lyophilized powder in the vial. This is a slightly old video, so the clarity may not be so good. Once you have injected it, you split that from into another vial, which is pre-autoclaved. So you have 1 cc, 1 milligram in 1 cc, and then you add 4 cc into each of those vials. So you have about 1 milligram in 5 cc. So you can share it with your cornea colleagues who would like to use it. And you can, we use it for about 2 weeks, and then we freshly prepare it again. We label it and store it in the refrigerator. So mitomycin C can be used. If you're not comfortable with using mitomycin C, you could use 5-fluorouracil. It's better to use polyvinyl sponges to soak them and keep in beneath the conjunctiva and pull forward the conjunctiva so that the edges don't touch the conj. So this is a large sponge we are using, but now we use smaller sponges, about 3 in number, and pull forward the conjunctiva. The sponge should release the mitomycin C. The sponge it should not absorb and retain the mitomycin C. It should release the mitomycin C, and the area is thoroughly washed with 30 cc, 15 to 30 cc of balanced salt solution. And lifting the scleral flap is something which is crucial, and this is where the novices get stuck. So it's important to get the apex off. We prefer to use a 15 number Baden-Powell knife, but of course you can even use a crescent blade for that. You could always bend the crescent blade straight and then try to do it instead of using angles crescent blade, which will be difficult to use as you would use in a manual small incision cataract surgery. And always have the assistant mop that area. That increases the visibility and shows you the edges where the flap is lifted off and where the bed is present. And always stop about approximately 1 millimeter from the limbus, so that you follow the Moorfield safe surgery system where you don't have to go really up to the limbus. But you must understand the punch has to be made a little anterior. The center part will be anterior, the periphery parts will be stopping short of the limbus. After you lifted the scleral flap, some situations we prefer to use anterior sclerotomy, especially patients who have very chronic angular closure glaucoma, who have very small eyes. They may not be ophthalmic. They may have the axial length of approximately 20.6 or 20.7, but they still present with chronic angular closure glaucoma. They may have very high pressures, hypertensive patients who are not getting controlled, young patients, and patients with associated abnormality of the anterior segment, like Sturge-Weber or eye syndrome, very high intraocular pressures. So we do a small anterior sclerotomy and infratemporal quadrant. And this is something like how you would do for a choroidal drainage. So we do it a little preemptively. And if at all the chamber shallows and the next day there is a choroidal effusion, the effusion can drain out from this region. So it prevents helps to allow the effusion to come out slowly, and the sudden decompression, which you should usually avoid. If at all it precipitates choroidal effusion, you have a little bit of drainage area. So the chamber doesn't shallow to the extent it would if you have a choroidal effusion at the back of the eye next postoperative day. So in myopes, this has found to be quite helpful, and usually choroidal effusion doesn't happen. But we had one patient who had such a effusion, and you could see an infratemporal large congenital swelling, which showed us that the effusion had drained slowly out of that region. The important thing is you have to cut full thickness sclera and see the choroid. And then that's your end point. Once you see that between the blades, Once you see that, you can close the conjunctiva. Many people will recommend you to cauterize that area, but cautery is not recommended. It's a temporizing measure only. You are not supposed to leave it permanently. So if there is no corneal effusion, that site will heal. If the intraocular pressure continues to increase, and if you have cauterized it, that site will not heal. So you will have many people will say you'll have a ectasia of the uveal tissue through that site. So it's better not to cauterize. Once the intraocular pressure remains low for a period of time, that site will heal, and you will not have, later on when the intraocular pressure rises, you won't have the ectasia. So that's it. You use the bicual suture to just close the conj. So in high risk cases, this is also a possible technique of preventing intraoperative complications. Just as you would use mannitol or super pinky to reduce the intraocular pressure. So parents, after you have done the anti-sclerotomy in high-risk cases, if you are not operating a patient with high-risk case, you can just go ahead with do a small paracentesis. Paracentesis is very important because it helps to test the integrity of the flap closure in the end of the surgery, and also to form the, so if you notice here, the paracentesis has not gone over the normal crystalline lens, it has gone over the iris. So it's better to avoid the paracentesis like a manual small incision surgery, which you would tend to do and bring the blade right over the cataractus lens. Trabeculotomy is done using the Kelly's Desmet punch. The punches come in various sizes, so the entry is made beneath the flap into the anterior chamber, and you could always inject a oro gel or sodium hyaluronate into the anterior chamber to form the chamber before you do the Kelly's Desmet punch. And the punches come in 0.75 to 1.5 millimeters. So many people will ask, how many punches am I supposed to do? So it's not the number of punches. The principle is that from the edge of the flap to the edge of the ostium, the dimension, the length should be minimum of 1 to 1.5 millimeters space should be given. So if you have less space between the edge of the flap and the edge of the ostium, you will have overfiltration. If you have more space between the edge of the flap and the edge of the ostium, you will have underfiltration, which will lead to scarring. So the distance between the ostia and the edge of the flap should be minimum 1.5 millimeter. Peripheral arrhytomy is the next step, and you all ask your assistant to hold the flap as you do the arrhytomy. The principle is that you have a broad-based arrhytomy. You pull the iris to the opposite side of cutting, and then cut it, and then you cut, and then the opposite side to give it a broad-based arrhytomy. And you inject and remove the debris, because the posterior pigment layer is more friable. It will always get loose, and it will obstruct the ostium. So you inject fluid to check for the patency and remove the posterior pigmented layer. The scleral flap is subsequently closed with 10-0 nylon sutures. We are here, if you see, you are using a releasable suture. You can use a single releasable suture in the apical region, and then you can apply interpreted sutures at the sides. So the releasable sutures usually come out first in the first follow-up visit, and that is for us about 15 days later. And then subsequently, based on the intraocular pressure, we remove the other sutures. So by the end of 1.5 months, all the sutures have been removed, or they have been cut with a laser suture lysis machine. And once you have done that, you titrate the closure. How we titrate the closure is that you inject fluid through the paracentesis, and the wounds will usually, the wounds of the scleral flap will expand. Once they expand, they will release some fluid. But again, don't inject fluid inside. If the eyeball is firm but chamber is formed and slight tap shows mild wrinkles, that is your endpoint. Next day, anywhere between, your pressures will be anywhere between 14 to 18 millimeters of mercury. I usually apply tight sutures, and my intraocular pressure on the first day will usually be around 20-21 millimeters of mercury. And then subsequently, we start releasing the sutures. So I don't target low pressure on the first day, because most of the patients come with a compromised optic nerve head. You require a little bit of normal pressure level for the optic nerve and the vasculature to function. If you reduce the intraocular pressure too much, they have suboptimal vision the next following day. So I don't target very low pressure, but I target low pressure as manipulations happen during the subsequent visits. The advantage of releasable suture is that you don't need many equipment or laser machine to remove it. You just need a simple forceps. The time is saved. We have about 20-25 forceps in our clinic with which we remove our the releasable sutures. They don't have to go to a separate room with a laser machine to have those suture lysis done. And the visualization of the suture is not a must. You don't really need to see the suture. You just need to see the suture on the cornea. And because you apply them very tightly, the immediate post-operative complications are very less. If you're happening to use Olagen, you must use releasable suture because through the Olagen, you cannot do a argon laser suture lysis. The disadvantage of the suture is that it leaves a track which can allow the infection to go into the bleb. So you have to either release the suture or cut it flush with the cornea. And the exposed stump may act as a windshield wiper keratopathy, which we have seen sometimes. And early removal can lead to shallowing chamber. And the last sutures, sometimes you're not able to remove it because they can break. So sometimes you may have to do an argon laser suture lysis for the last suture. Special situations which require augmentation or something like a device-assisted trabeculectomy, juvenile open-angle glaucomas, glaucoma aphakia, high myopia, young patient developmental glaucoma, uveitic glaucoma. So for them, we use Olagen. It's not available now, but with the, I think, improvement in the COVID-19 situation, you may start getting it. This is considered as an alternative to mitomycin C. It's anti-scarring agent without chemical inhibition and results in a prominent filtering bleb with successful surgical outcome. It's biocompatible, biodegradable, comes in a ready-for-use package. So this is how we use it. We have the flap, which has been created. The ostium has been created and the PI has been done and the flap has been closed. After that, the Olagen is kept on the conjunctiva, on the squirrel flap, and the conjunctiva is closed. And it comes in various sizes. We are familiar with the use of the 6 mm by 2 mm model. And once you have sutured the flap, you keep the Olagen on the flap region, put it near the apical region as posterior as possible, wet it, and push it back in. In many situations, you would find that you have a nice diffuse bleb. And when you suture, don't take a bite through the Olagen because Olagen can act as an idus for infection. So you don't want the Olagen to be taken in the suture bite. And tightly close the conjunctiva with wing sutures. So once you close the conjunctiva with wing sutures, you will find that. And this is how you close the conjunctiva even without Olagen. You take wing sutures on your side, on the right side and the left side of the flap, and bring forward the conjunctiva so that you have a horizontal line, a thick band of conjunctiva, which prevents aqueous to leak from the wound area. So indications, as I mentioned, in these difficult, if you have a patient with one eye complication with mitomycin C, or patient with rheumatoid arthritis, and a patient with traumatic glaucoma, these are the main indications for Olagen. And for testing the bleb, look for the filtration and leaks. And if it's not forming, press the posterior lip of the flap to check for the leak, and paint the bleb with fluorescein to check for leaks. That is some tests which you can do for wound leak and identification of a good closure. Post-operatively, we use topical steroids. For the first 2 days, we give loading dose and then taper for about 8 to 12 weeks. We always use atropine in all our TRAP patients, irrespective of the condition of the diagnosis. We use atropine, which is an ointment, which is for 10 days. It's thrice a day, twice a day, and then OD for 10 days, and antibiotic drops for 15 days. In suboptimal situations where you have very high IOP, chronically medicated patients, aphakia, non-ophthalmos, you have to change our strategy. And patients who are hypertensive, either they have high BP or they've been recently diagnosed, neovascular glaucoma, very high IOP you have to control. Especially we have a good good number of patients who come through our low pay section or the camp section, and they present with chronic glaucoma, which has not been diagnosed. And many patients have secondary glaucoma. Many of them are even monocular patients. So we use intravenous mannitol, oral acetazolamide, and anti-sclerotomy, which I've shown. When you do a paracentesis, do a very slow decompression. Sudden decompression will cause the chamber to shallow and subsequent post-operative complications, intraoperative complications. And patients on long-term maximally tolerated medical therapy, you will find that the ocular surface is totally altered. The conjunctiva is so hyperemic. The conjunctiva is also very friable because of the so much of preservative containing drops which have been applied for so many years. Be very careful of congenital buttonhole formation, and you'll find that as you are cauterizing, as you are dissecting, doing a peritomy, severe bleeding, oozing will occur. The sclera also, the episcleral tissue fibrosis with the sclera so much that as you lift your flap or do episcleral dissection, you'll find that the sclera sort of starts peeling also. So you have to be very careful in such eyes. And these eyes have a tendency for rapid scarring, and you may have to plan very early bleb needling for such eyes. Even within 2 months, you may have to plan for a bleb needling. Longer duration of mitomycin C is one way of overcoming such complication. So how do you apply longer duration is that you apply 3 sponges and then remove the sponges, keep them for 2 minutes. After removing the sponges for 2 minutes, so remove and reapply the sponges with fresh mitomycin C for 2 minutes. So don't apply 3 sponges and wait for 4 minutes. That's not the way mitomycin C usually works. So you have to apply fresh sponges for 2 minutes and then again repeat the fresh sponges for 2 minutes. We use this for patients who have very low central corneal thickness, patients who are chronically medicated, and patients who have in which we are targeting very low intraocular pressure. So this works pretty well in such eyes. You can see this patient is a patient with post PKP and intraocular lens implantation. So this patient requires, because of the procedure and the inflammation, is basically a patient of eye syndrome. He requires such application of mitomycin C. And nanophthalmos is another condition. You have to be very careful. So plan with intravenous mannitol. This is another difficult trap situation. Anticipate choroidal infusion and suprachoroidal hemorrhage. And sequential vitrectomy may have to be done if you have a possible in which you have a very very shallow chamber and you're not able to form the chamber. It almost becomes a malignant glaucoma sort of a situation. So long-term dose response study was published by R.K. sir in Tirunelveli, and you would see that at that time, if you use mitomycin C for about 4 minutes, as I mentioned, you have slightly high rates of complication, which are not non-cataract related complication. But at that time, the Moorfield safe surgery system was not very popular, and or it was not come out in people would not have known at that time. So maybe less number, but now we changed that system where we apply more sponges most posteriorly. And now with this, we feel that the non-cataract complications are actually far much less. So you could also do bleb needling. Coming to the topic, what will happen if you were to have a failure. So you could do a bleb needling for management of post-trap eyes. And you would see that we are doing this in an eye with an origin bleb which has scarred. And one interesting aspect is you could use an AC maintainer in such eyes. The AC maintainer will allow you to identify when you have reached an endpoint, that is the flow of aqueous from the anterior chamber into the bleb area. And if it's not happening, you may have to enter the anterior chamber and open the ostium also. There are other techniques available for ab interno lifting of the scleral flap, which you can use using a Grover spatula. So here we are entering the anterior chamber, and you find that the AC maintainer helps in the flow of fluid from the anterior chamber into the bleb region. Because the tissue is very much fibrosed, you can see the needle in the anterior chamber, and as you withdraw, you will find some gush of blood from the bleb area into the anterior chamber. That gets reversed very quickly because the intraocular pressure is raised because of the AC maintainer, and the blood will come back into the bleb region. And once you have a soft globe, you can remove the AC maintainer. You can give an injection of Decadron in the posterior to the bleb. Again, the steroids have to be really pumped up. It's if you have a collagen-based bleb like this, avoid injecting mitomycin C. Otherwise, you can do a injection mitomycin C first and then followed by a bleb needling. So outcomes, we have our data from the bleb needling in primary glaucoma with filtering bleb. So the if you see, the number of patients were about 60, and the mean preoperative intraocular pressure before bleb needling was about 23 millimeters of mercury with a standard deviation of 7.86, and and at 6 months you have an intraocular pressure of 16 millimeters of mercury with a standard deviation of 4.32. These are our primary glaucomas only, primary open angle and primary angle closure with or without combined procedures. And the univariate analysis was significant for baseline IOP. So if you have a raised IOP before, you would have a better outcome. And at diagnosis, primary open angle glaucoma patients fared the best, and younger age patients fared slightly better. Whereas the multivariate analysis was not significant for age, time to bleb needling, DCVA, intraocular pressure pre-op, or gender laterality, and intraop complications. So because of this, we feel that you could give a shot of bleb needling after your TRAB before planning for either addition of medical therapy or even planning implant surgeries. Thank you for patient listening.
Thank you, sir, for that excellent presentation. Actually, it was the useful tips that you have given me. It will be helpful even for seniors and also for the beginners. How to do a proper trabeculectomy, how to do a pre-op evaluation. Everything you have mentioned in your presentation, and it was really very helpful. Thank you, sir.
Thank you, madam. Thank you.
Thank you, ma'am. Thank you, sir. Next, say we have tried our best and yet the glaucoma is refractory. So what do we do next? Dr. George Puturan will help us tackle that. Dr. George Puturan is the Chief Department of Glaucoma, Arvind
Sorry,
Eye
Danya,
Hospital.
sorry to
His
interrupt.
area of interest is the use of glaucoma drainage devices.
Danya, I'm sorry to interrupt. I think Dr. George hasn't joined it. He has some other meeting because we had to prepone because of Dr. Rajul's inconvenience. I had informed him, but he has a meeting at the Aravind Eye Hospital. So I request Mr. Ankit to share Dr. Venkatesh's presentation. Ankit, are you there? Let me call Ankit, and I think we'll have to share. Dr. Venkatesh is unable to attend because he's away on a trip, and he has shared his presentation. So that will be shortly relayed. Sorry for that short delay. The Dr. Venkatesh's presentation will be on now. Please wait for a few seconds.
I thank Angamali Little Flower Eye Hospital for conducting this excellent symposium and also giving me this opportunity to talk about this very important topic. Angle surgery for India, and how do we get prepared for this? So glaucoma surgery is not rewarding, for even glaucoma specialists sometimes, because it takes longer than cataract, much more post-operative care than cataract, longer visual rehabilitation, and unexpected surgical outcomes. Sometimes you can get a lot of these complications even after years after surgery. So there is a kind of negative social marketing. So glaucoma team has been always looking at high safety profile surgery, which is less invasive and also has got a quick recovery. And this is the time when we have to explore the MIGS, the minimally invasive glaucoma surgery options. Because most of the MIGS are now ab interno approach. It spares your conjunctiva for future conjunctival-based surgeries. And it is safer and less invasive way of reducing the intraocular pressure. And of course, once you get good results, you can reduce the dependence on topical medication. Maybe 3 medications can become 1 medication. And you can always combine it with cataract surgery. And also there is a quick recovery. It improves the quality of life also. But the most important thing is who will benefit. Mainly it's the open angle glaucomas. Still for narrow angle glaucomas, it may be cataract or trabeculectomy or the other procedures to control the intraocular pressure. But the MIGS would definitely benefit patients with open angles, especially mild to moderate stage glaucoma patients. Patients with ocular hypertensives on 1 or 2 medications. And people who have early glaucoma and also who need cataract surgery, we can combine this. And people with ocular surface disorders who cannot tolerate the medications or who are not compliant to the medications, who are not kind of adherent to their anti-glaucoma medications. When you talk about MIGS, there are several options, but the enhanced Schlem's canal option, which is the angle surgery, is the one which we have to take a close look. We have options like trabectome, eye stent, hydrus, GART or the gonio-assisted transluminal trabeculotomy, and the Cahoog dual blade. And then you have suprachoroidal option, the eye stent supra and CyPass. Unfortunately, CyPass is already gone, and eye stent supra is yet to be available in Indian market. And also there are options to destroy the ciliary body in the form of ECP. So when you are talking about MIGS or angle surgery for developing world, most of the devices are yet to be available, but some are already available. Definitely cost is a factor, and definitely it is, we don't have very good evidence in Indian eyes, but we have a lot of publication from the Western world about the results of the MIGS. At this point of time, we have eye stent, which is a kind of cost prohibitive option. It is available, but it is very expensive. The viable options are doing a suture GART, a gonioscopy assisted transluminal trabeculotomy using a phioprolin. And the other option is where you can use this Cahoog dual blade for multiple patients, 4 to 5 patients. So it becomes less expensive. So eye stent is available for almost a decade now in the Western world. There are more than 100 papers looking at the results, comparing between standalone cataract versus cataract and eye stent. You can see this is an eye stent inject. Now it's available in India. It's very, very easy to use. It comes with a small injector, and then you take it, you do the intraoperative gonioscopy, you identify the trabecular meshwork, and then you inject this eye stent inject into the Schlem's canal. No, it's just a click. If it is done at the proper site, with a little bit of learning curve, you can comfortably do this procedure. Now you can see we have put a couple of eye stents in this patient, and definitely it works to reduce 1 or 2 medications for somebody with a moderate damage with a high intraocular pressure. The next important thing which we will discuss is about the gonioscopy assisted transluminal trabeculotomy. it's a good option for open angle glaucoma. And usually it is performed with this eye track micro catheter, which is again expensive. Now you may have to use one catheter for each patient. And the other less expensive way of doing it is with pyoprolin suture. And we have found that pyoprolin suture is a kind of cost-effective option which gives almost similar results as an eye track catheter. But these are the important things which somebody should have before even trying to do this procedure. A low temperature cautery, which is very important to kind of make a small flange in the suture. A Swan-Jacob gonioprism is a must, and practicing intraoperative gonioscopy before some of these procedures is again very important. Pyoprolin suture, 25 gauge MVR blade, Healon GV. You need very good viscoelastics like Healon GV, MST forceps and McPherson forceps. And I'll show you how we use some of these instruments. So here you can see the low temperature cautery making a very small flange. You can't do a big, just to show you the comparison between the two. It's a very small flange you do. And there are two ports. One is the main port and another is the side port. If you are doing a phaco, you can make a phaco incision in the temporal side. And putting more viscoelastic inside and over the cornea and positioning the patient is very important. So you have to position the patient in such a way that the eye is away from the surgeon and the microscope is toward the surgeon. You have a 30-degree slant. And that's an MVR blade which is used to make a small nick in the pigmented area of the trabecular meshwork. And you can see it, you open up the Schlemm's canal like that. And sometimes you may have reflex bleeding. If you have reflex bleeding, you inject viscoelastic and then you start inserting the flanged part of the pyoprolin suture. So you have to gently insert the catheter clockwise by clockwise. This is again an indirect gonio which is happening in between to confirm where it actually is. And then you again continue with your direct gonioscopic evaluation. Whenever it is crossed 180 degree, there will be a little bit of resistance, but you continue to push and you can see it's coming on the other side. And now carefully you hold that with your forceps. Now this should go on top of the existing suture, and using a McPherson forceps through the side port, you do this 360-degree trabeculotomy. So all these are very important to practice intraoperative gonioscopy carefully, using the MVR blade to kind of open up the Schlemm's canal and then inserting the suture. And at the end of the surgery, you can see a nice blanching happening. And this gives you a good evidence that 360-degree, there is enhanced Schlemm's canal outflow. So this is how you do a suture guard. So definitely by doing this, you preserve conjunctiva for future surgeries. It's a kind of less expensive option with the minimal complications. We have seen patients having microhyphema. Sometimes they resolve in a day or two. Very rarely you have major complications. Very minimal risk for infection because most of it is just intraoperative. And with cataract or without cataract, you can add intracameral moxie to avoid infections. And definitely we can reduce the number of follow-up visits than our regular trabeculectomy procedures. And we have seen in our hands, short-term results are very good. Up to 2 to 3 years, the results are very good. And definitely there is a learning curve in using intraoperative gonioscopy and also some of these techniques. And we have to look at long-term results. But we have evidence from US, from Davinder Grover, who has done this procedure for several of his patients, and he has published 2-year, 5-year results, and it is very promising. The next option in our hand at this point of time is the Kahug dual blade. No, it's basically a goniotomy blade, which is again introduced almost 5-6 years back. It is available now in India. From All India, it's available. During the conference in Mumbai, it was released. It basically removes the trabecular meshwork. No, you kind of do a clean shaving of the trabecular meshwork for certain clock hours. What happens in GART is you have residual trabecular meshwork. You're doing a trabeculotomy, but the residual trabecular meshwork is there. Whereas in a trabectome, you do an electrocautery, which damages the surrounding tissues. Whereas a KDB, there is a complete removal of trabecular meshwork. So there is less fibrosis and better visual outcomes. So I'll show you how it is being done here. So this is a Kahoot dual blade. So there's a dual blade and there is a plate behind it. So once you introduce the dual blade into the Schlemm's canal, it peels the trabecular meshwork. The heel of it will be on the Schlemm's canal, and then you can remove the trabecular meshwork for a couple of clock hours on either side, like two clock hours on one side and the 2 clock hours on the opposite direction. So basically, again, it opens up the anterior chamber to the Schlemm's canal. It makes a direct connection. Now you can see the reflex bleeding from Schlemm's canal, and you need to use a nice viscoelastic to pressurize that area and also clear and see what's happening. And then the peeled trabecular meshwork can be washed away. So this is how you do a Kahoot dual blade. So you use the sharp end to insert into the trabecular meshwork into the Schlemm's canal, and the dual blade will peel the trabecular meshwork. So this is a very special device. It is definitely expensive, but you can use for multiple patients. They recommend to use for maximum 5 patients, and beyond that, the knife may not be very good. You have to ETO sterilize it and use it. But there is another way of doing it, and we have tried doing it. We call it as the bent ab interno needle goniectomy. You basically bend a 25 or a 26 gauge needle at the tip, like a Kahoot dual blade. It may not be as similar as KDB, but it can do the job. So carefully, if you see, we are just bending a 26 gauge needle here. At the end of it, no, it's like a beak there. And then you can see already there is blood in the Schlemm's canal, so you can recognize it very nicely. And then you gently go inside, like how you did with the sharp end of the Kahoot dual blade. You enter into you tear the trabecular meshwork, enter into the Schlemm's canal, and carefully peel the trabecular meshwork for a couple of clock hours in the clockwise direction. And now you can see it's going in the anti-clockwise direction. So people can even start bending and touching the angle, to get a feel of it, and then try this bang, and then devices can, like KDB, can become very easy to use. So there are a lot of publications again on KDB, which is there. There is a lot of evidence that it works very well, not only as a standalone, but also with cataract surgery. And it's got a mild to moderate reduction of intraocular pressure, and it can get some of your anti-glaucoma medications off for the patient. But the most important thing, for the general ophthalmologists who are attending this symposium, I would insist that maybe the future of MIGS is not only for glaucoma people. Even cataract surgeons will start doing a lot of MIGS, as what's happening in US and in Europe. Now, a lot of devices like iStent, Hydrus, the KDBs are being used by most anterior segment surgeons because they add to the cataract and they can reduce the intraocular pressure also. So it's very important to learn intraoperative gonioscopy. Positioning the patient is very important. Turn the patient's head away from you and tilt the microscope towards you. You need a 30 to 40 degree angle. Microscope is tilted and the patient's head is rotated. And this is very important, a high viscosity OVD, especially Heal-On GV. Here we use our Oro gel, which is equivalent to Heal-On GV, which gives us good results. And try to keep patient's head above the heart, something like this. Keep your table in a slanting level. So the head is on top, the heart is below the head level, so that you won't have much of a reflex of blood into the Schlemm's canal when you're peeling the trabecular meshwork. So this tip helps some of the patients. Okay, you can see here. So start doing this in your cataract patients. You can do either before your cataract surgery or after your cataract surgery. Both you can practice. Like you see here, you inject viscoelastic into the anterior chamber, and then you put the visco on top, then get your Swan-Jacob lens and start seeing the angle. Once you start seeing the angle, you'll get the confidence. Once you start seeing the angle, touch the angle, touch the trabecular meshwork with some instrument, maybe a cyclodialysis spatula or even your cystitome needle. Just go and touch it, feel the angle, and then you continue with your cataract surgery. Or after removal of the cataract, your chamber will deepen. Then also you can do this to see whether you can see the angle better. So in conclusion, angle surgery, especially the MIGS options for angle, is a potential to solve a variety of problems in glaucoma management, especially in open angle glaucoma and ocular hypertensives. Because it preserves the conjunctiva, it buys you time. Wherever you don't want to touch the conjunctiva. You are doing a cataract, you want to add something to the patient. This is a very good option so that you can postpone your invasive procedures. And we have found that it definitely improves the quality of life of patients. There are potential limitations which I have highlighted. We still need to see results in Indian eyes, long-term results even in European eyes. And some of them are very expensive. So we need to look at the cost effectiveness of these options. And very important is the patient selection should be also ideal because their expectations may be high when you're doing procedures like this, which are expensive. So we may have to kind of meet their expectations. And so it may not be a standalone procedure for somebody with a very high intraocular pseudo-exfoliation glaucoma, pigmentary glaucoma. So some of these conditions, it may not be really a good option, but it can buy you some time before you do invasive procedures like trab or tube. And future is very bright. There may be a lot of devices which will be available in India. And I'm sure a lot of young innovative surgeons here also will think of options like this, where we can improve the way we treat glaucoma and the way we do angle surgery. Thank you.
Thank you, sir. That video was highly helpful. Though trabeculectomy is the surgical gold standard, there is hampering of the conjunctival anatomy. And also because these patients are using long-term anti-glaucoma medications, it also produces changes in the conjunctival histology. Hence started our search for surgical modalities with conjunctival preservation. Newer innovative surgeries in glaucoma like MIGS is widely done abroad, but are a little expensive when it comes to Indian scenario. And that is where Dr. R. Venkatesh's innovative mind and skills come into picture, where he combined the wisdom with the Indian resources and technology to bring about cost-effective angle surgeries. He is a chief medical officer at Aravind Eye Hospital, Pondicherry. He closely mentors young ophthalmologists of Aravind in innovations, and he has several publications in peer-reviewed journals and surprisingly has won several awards in international film festivals as well. Now let's move on to the last session in the treatment module. Dr. George Puthuran, sir, who is here already. Okay, say the glaucoma is refractory. So now what do we do next? Here, Dr. George Puthuran will help us tackle that. Dr. George Puthuran is the Chief of Department of Glaucoma, Aravind Eye Hospital, Madurai. His area of interest is in the use of glaucoma drainage devices in refractive glaucoma. He worked closely with Aurolab, the manufacturing wing of Aravind Eye Care System, in the evolution and widespread use of an affordable aqueous drainage implant, and has extensively published on its safety and efficacy outcome. Over to you, sir.
Thank you. Thank you very much. I'll just share my screen.
Sure, sir.
Is it visible?
Yes, sir.
Good. So now over the next 20-25 minutes, the plan is to go through principal indications, designs, and surgical technique of aqueous drainage implants. I don't think we will have much time to cover the complications part. So all aqueous drainage implants have a silicone tube that shunts aqueous humor from the anterior chamber to a plate situated in the equatorial region of the globe. So following several weeks after surgical implantation, a fibrous capsule forms around the end plate. And a fact which is common to all episcleral plates of different glaucoma drainage devices are that this fibrous plate is made of, this episcleral plate is made of material which is biocompatible. That is, the fibroblast does not adhere to it. So the aqueous that drains through the tube from the anterior chamber collects the potential space between the episcleral plate and the fibrous capsule. And from here, it passes by passive diffusion through the capsule and is absorbed by the periocular capillaries. So the indications are medically uncontrolled glaucoma where trabeculectomy has failed or is unlikely to succeed. So glaucoma drainage, these are situations where trabeculectomy is unlikely to fail, unlikely to succeed. And various secondary glaucomas like neovascular, uveitic, epithelial or fibrous ingrowth, iridocorneal endothelial syndrome are all good candidates for tube implantation. Again, eyes that have undergone previous ocular surgeries like penetrating keratoplasty, scleral buckling procedures, pars plana vitrectomy with silicone oil, various childhood glaucomas, especially the secondary childhood glaucomas, the developmental glaucomas like Axenfeld, Rieger, and aniridia, and also primary childhood glaucoma where the angle surgery has failed or failed trabeculectomy. So here is a publication where we found that placement of glaucoma drainage device resulted in a lower intraocular pressure and a higher rate of surgical success compared to trabeculectomy with mitomycin in eyes with glaucoma associated with aniridia. So this is a primary tube in aniridia versus trabeculectomy in aniridia. Another indication, again, medically uncontrolled glaucoma, where in this group of phacomatoses, especially the Sturge-Weber syndrome, due to the high risk of intra and post-op supracorneal hemorrhage, surgeons usually prefer to put in a tube as the primary surgical procedure of choice if IOP is refractory to medications. Again, glaucoma in aphakia, children who have undergone congenital cataract surgery. This is also a group where, again, the risk of intra and post-op supracorneal hemorrhage trabeculectomy is quite. Surprisingly, in one of our publications where we looked at the results of the RD in pediatric glaucoma, we found that glaucoma after congenital cataract surgery, especially glaucoma in aphakia, was the most common type of glaucoma in our patient cohort, in this cohort of refractory pediatric glaucoma. So coming to the implant designs, all of them have a silicone tube connected to an episcleral plate, but differ in the size, shape, and material from which the episcleral plate is made, and also differs depending on whether the implant has a valve or a non-valved implant. So Ahmed glaucoma valve is the prototype valve implant. Nowadays, the episcleral plate is made of silicone. FP7 and FP8 are very commonly used, especially the FP7 with a surface area of 184 millimeters square. And there is a valve mechanism, a silicone elastomer membrane valve mechanism that separates with an intraocular pressure of 8 to 12 millimeters of mercury. So this is a unidirectional flow and pressure dependent flow. Postgraduates should know that Krupin valve with this is an example of another valve implant. So the non-valved implants are the Barwell glaucoma implant and the cost-effective Orolab aqueous drainage implant designed on the state-of-art 350 millimeter square surface area of the Barwell glaucoma implant. So the advantage is you have a larger episcleral plate which can be implanted in a single quadrant of the eye. Voltano implant is another popular non-valved implant, pediatric single plate, double plates, made of polypropylene, and Ahmed Clear Path is a newer addition to the non-valved implant. Coming to the surgical technique, there are some pearls which have to be followed. The episcleral plate of the anterior edge of the episcleral plate has to be 9 to 10 millimeters posterior to the limbus. For non-valved implants, you need complete temporary tube occlusion with 6-0 vicryl suture. So that is spontaneously dissolves by about 5 to 6 weeks postoperatively by the time the fibrous capsule forms around episcleral plate. Again, tube placement is critical. We need to have an adequate scleral tract. It's good to embed the tubes in the patient's own sclera and also to position these tubes as far away from the endothelium as possible. If you have a slit on the cornea, on the tube and the iris, we should ensure that the distance between the slit on the tube and the corneal endothelium is as far away as possible. This distance from the slit on the iris to the tube is as close together as possible. So this should be our ultimate aim, and this principle should be followed right from the entry in the anterior chamber, right from the entry into the anterior chamber. I have an edited video of a non-valved implant. This is a child with glaucoma and aphakia, history of congenital cataract surgery, intraocular pressures refractory to medicines. And a non-valved implant, the 350 millimeter square RD is our preferred primary surgical procedure of choice in such a clinical scenario. So the wings of the RD are designed to position beneath adjacent rectus muscles. So this is the superior rectus being identified and isolated, and space is being created beneath the superior rectus muscle and the lateral rectus muscle. So this is your 350 millimeter square episcleral plate. And the patency is checked by injecting balanced salt solution through the tube using a 27 gauge cannula. So all our non-valved implants for the past 6 months receive a intraluminal stenting with a 3-0 supramet. This is 3-0 multifilament nylon. It's inserted into the anterior chamber, and then the routine ligation with 6-0 vicryl happens over the supramet suture. So again, this is one sign which shows that the tube is completely occluded. You can see those bubbles. It's usually 2, 1, 1, and 2 and 3 ones. That is the knots which we prefer. So this is the superior wing of the RD going in underneath the superior rectus muscle, and then the lateral wing being positioned beneath the lateral rectus muscle. So one of the advantages of this beautiful design is that once this implant is positioned beneath the rectus muscles, anterior migration of the episcleral plate, which we have sometimes observed with the urban glaucoma valve, is totally taken out of the equation. If you pull it forward, it doesn't come beyond a certain beyond the muscles, but lateral movement and posterior movement is freely possible. So this implant is fixed to the sclera with 9-0 nylon suture, making sure that the knots are buried into the positioning holes to prevent exposure to the conjunctiva. So this is tube placement in the anterior chamber. As a 4 millimeter scleral tract is positioned 2 millimeter medial to the original position of the tube. It's a 4 millimeter scleral tract positioned 2 millimeter medial to the original position of the tube. And a 23 gauge needle is used to generate a scleral tract through which the tube can be threaded into the anterior chamber. So the initial movement of the needle is sclera parallel, and at a particular position, it has to abruptly change to iris parallel to visualize the needle in the anterior chamber as close to the iris as possible. The tube was initially trimmed 2 millimeter anterior to the limbus. So we find that trimming the tube 2 millimeter anterior to the limbus and inserting it into the anterior chamber through a tract 4 millimeter in length and 2 millimeter medial, whether it's the right eye or the left eye, the tubes get into the anterior chamber. It's the medial aspect. So it is a sinuous route. So this is 10 millimeters. 10 millimeters, one of the important principle, and you can opt for venting slits for immediate postoperative IOP control. So the supramet suture is trimmed and tucked subconjunctivally. the advent of supramed suture in the recent past has a huge potential to further make this non-valved implant surgery much more safer. Usually, we wait for about 7 to 8 weeks before we pull out these supramed sutures, and that too only if the intraocular pressures are refractory to medicines. So the Ahmed glaucoma valve, probably your conjunctival incision is slightly less than your non-valved implant because the surface area is slightly smaller than the barbell-like RD. It is 184 millimeters square. Again, what postgraduates need to know here is priming is a very important step in a valved implant. So you push balanced salt solution with a 27 gauge cannula, and here is where the silicon elastoma membranes are separated and the valve function is put in place. Whereas in a non-valved implant, it is just the checking of the tube patency. Rest of the steps are all similar. Making sure that you don't hold the Ahmed glaucoma valve anywhere near where the valve is situated, and then the anterior edge of the episcleral plate is positioned 9 to 10 millimeters in posterior to the limbus. It will be a good practice to actually measure 10 millimeter and mark it while inserting the Ahmed glaucoma valve, since here the wings don't go underneath the muscles and inadvertent anterior migration can happen. So there is no role for tube ligation here. I just skip through this. So everything else is the same. Which is again a 4 millimeter scleral tract, 2 millimeter medial to the initial position. We have found that embedding these tubes in the patient's own sclera has made a huge difference to the rates of tube exposures and tube exclusions in our practice. It is a difficult art to master, a surgical step to master, but once mastered, I think the tube surgery becomes much more safer. So for those of you who are interested, can look at this paper published in the AJO, where we have compared the results of tube implantation with and without scleral patch, and we have found that it's as safe and effective as an autolab aqueous drainage implant placed with the patch graft in both pediatric and adult population. So one of the two things that have to be noted here is, in the absence of a scleral patch, the conjunctival elevation is much less. The ensuing conjunctival inflammation is also much less, and the healing seems to be much better. Again, there is no abrupt change from the conjunctiva to the cornea. It's a much smoother, as anatomical as possible, and the healing and incidence of things like Dellens formation are minimized. Coming to sulcus placement of tubes, indications are when there is anterior PAs, especially in post-PKP. Again, see this slit on the cornea, on the tube and the anterior lens capsule. This distance is maximized in sulcus placement. Again, you can take advantage of anterior PAs in situations where, in like Axenfeld-Rieger syndrome, glaucoma following congenital cataract surgery, if there is an anterior PAs, tubes can be placed in the sulcus. Iridocorneal endothelial syndrome is another indication where there is anterior PAs. Neovascular glaucoma, especially when combined with cataract surgery, is a good candidate for sulcus placement. High peripheral anterior synechiae on gonioscopy, like in situations of uveitic, clinical scenarios of uveitic glaucomas. So what we have noticed is, for anterior chamber placement, I was mentioning about 4 millimeter scleral tract. What we have seen is, this is a 23 gauge scleral, 23 gauge needle, and this is 2.8 millimeters in length till here, till this part. And then there is a slight slant, and after the slant, this is 3 millimeter length of the needle. What we have found is, once this needle is inserted into the 4 millimeter scleral tract till the 2.8 position, and then it is between the 2.8 and the 3 millimeter where the dramatic dip of the needle happens into the anterior chamber. And we have found that if the chambers are very deep, we can afford to dip at around 2.8 millimeters. If the chambers are slightly more shallow, we can dip at about 3 millimeters. It is this margin where we play around with to maximize the distance of the tube from the endothelium. Coming to pars planar tube insertion, can be done with concomitant vitreoretinal surgery, especially in eyes with silicone oil glaucoma, silicone oil glaucoma scheduled for silicone oil removal. Inadequate space in the anterior chamber, where you don't have adequate space even for sulcus placement, even in phakic eyes, you could do a lens sparing vitrectomy and place the tube in the vitreous cavity. Again, some situations like microspherophakia, where it's combined with the lensectomy, glaucomas which are refractory. So in pars planar tube insertion, we trim 3.5 millimeters of the tube after draping it over the cornea, and then leave it to our vitreoretinal surgeon to do a complete vitrectomy. So once the vitrectomy is complete, through one of the sclerotomy ports that is in the supratemporal quadrant, the tube can be easily inserted into the vitreous cavity. Again, one very important prerequisite is you need to have a complete vitrectomy before planning a pars planar tube insertion, which means you need to have an adequate shaving of the vitreous base also. This was a surprise. This was a post-traumatic glaucoma which had a vitrectomy and lensectomy. We placed the tube in the pars planar, but we were surprised at 8 weeks post-op, we had vitreous occluding the tube and the tube, compromising the tube function. We had to do a re-vitrectomy. Postgraduates should know that a pars planar clip and Hoffman elbow are available from companies that supply the Ahmed glaucoma valve and the Babel glaucoma implant respectively to facilitate pars planar tube insertion. Though to be very frank, I have never had to use either of the tube for pars planar tube insertion. For those of you who are interested in more details about pars planar tube insertion, we have published our results of the Orolab aqueous drainage implant, where the indications, the technique have been described in some detail. We have also now published and found that the initial outcomes of the affordable Orolab aqueous drainage implant, the non-valved version of the Indian version of the Babel glaucoma implant, and we have found the results both in adult and pediatric refractory glaucoma comparable to those published earlier with the initial results with Ahmed, Molteno, and the Babel in a similar cohort of patients. So some of the things which we have found after we have started using more and more non-valved implants is our incidence of these tenon cysts and pleb encapsulations, which were very common with the Ahmed glaucoma valves, have been minimized to a great extent with the use of this larger surface area episcleral plate of the Orolab aqueous drainage implant, which predisposed to much thinner walled low profile plebs. And also we used to prefer infranasal quadrant as our quadrant of choice if we had to implant a second tube. And over the last couple of years, this is a change in practice which we have observed. We found that the infranasal tubes don't seem to be doing well in the long term. The incidence, the IOP control and the incidence of tube exposures were found to be more with tubes placed in the infranasal quadrant in the pediatric population compared to the supratemporal quadrant, even though in the adult population, it was infranasal RD placement appeared to be an equally safe and effective surgical option compared with supratemporal RD placement. So now, if we have to place a second tube for some reason, where the IOP is refractory to the first tube, to refractory to the medicines, and probably laser cyclophotography, supranasal quadrant is our go-to quadrant of choice for the second tube. Also, 3-0 Supramid, it's a 3-0 multi-filament nylon, which has been developed by Orolab after great effort. And this has again has immense potential to increase the safety profile of non-valve implants. Every non-valve implant gets an intraluminal Supramid stenting in our hands. And that sudden collapse of the anterior chamber at 5 to 6 weeks post-operatively, when the vitral ligature suture dissolves, is no longer observed. And if pressures are good, we look at the episcleral plate. If the ridge is very prominent, pressures are high, probably we take out the Supramid about 7 to 8 weeks post-operatively. Otherwise, if the ridge is obscured, the bleb is formed well, pressures are good, we don't mind leaving the Supramid in place long term, especially in the pediatric group. Thank you very much. Before any questions, I'm extremely thankful to Dr. Girija for this opportunity. It's been a very long association with Little Flower, though this is the first invitation I've received. And before I take any questions, I would like to, this is my father this is a time where he was doing MS ophthalmology in Aligarh Muslim University, and I would request anybody from Little Flower to identify this Jitendra-like personality seen in this photograph. Thank you once again, Dr. Girija, for the opportunity. I have stopped sharing. Dani, I've stopped sharing.
Madam, you're not audible.
Yes, sir. Ma'am.
I couldn't identify the person you have shown in the picture, sir.
Anybody else could identify?
Madam, probably Madam can identify. I don't know.
That was Dr. E.J. Mani.
E.J. Mani, oh, yes. I thought it's Mani, sir. Then.
They're all very, very close
anyway,
friends.
It's nice to see him. So they were like, they studied together, or they had a close association?
They studied together, MS.
Your father and actually, Mani sir
Hi, George. Good to see you, man.
Very nice to see you, Arup sir, after a long time, even though it's virtually.
Yeah. Is this, or the session talks are over? Are you still online, or we have come offline?
Actually, ma'am, I think her network has some problem. As of now, our sessions are over, sir. All the sessions are over for today.
We are still live, sir. We are still live.
I mean, we can maybe come, if there are no other questions or anything, we can, So I just wanted to ask you, Ganesh, when you follow up these needling cases over a period of years, how do they do? I mean, it is just an immediate reduction of intraocular pressure for a few months, and again you have to repeat it, and then finally go for another surgery. Or, I mean, what has been not an isolated case, but overall, how do they do?
Overall, the qualified success is about 75%. That means they require medication for over a 2-year period. And you can repeat the needling. So supposing I'm planning, for example, implant surgery, I would repeat a needling, try that, and then plan for implant surgery. Why that is so, it depends on the age of the patient also. So supposing I'm looking at a patient who is like, let's say, is 74, 76, then I wouldn't like to put an implant in that patient, because 4 years down the line, they may start developing hypotony, because more than 80 years of age, patients, they don't secrete so much of aqueous humor as it was when they were young. So if I'm looking at a patient who is close to the 80 plus 8th decade, I wouldn't like to put an implant. But if I'm looking at a patient who is less than 76, then I would do a repeat needling. That's what I sort of plan.
Okay, thank you. So another aspect I really appreciated that you highlighted was the concentration of mitomycin C. So you refer to a study, Dr. Allen Robin, 1997. So that was the time when we were using 0.4% mitomycin C for 4 minutes.
Correct,
so that,
correct.
Around the same time I started private practice, and I did a lot of cases using this concentration. So
yes, sir.
Then
that
subsequently,
particular arm,
years later, I started seeing these patients with huge cystic blebs.
Correct. That particular study had that arm 0.4 for 4 minutes.
Yeah.
Okay, so what happened within 3 months, within 6 months, they had discontinued that particular arm. So there were 4 arms in the study. One was placebo, 0.2 for 2 minutes, 0.2 for 4 minutes, and 0.4 for 2 minutes. The 0.4 for 4 minutes were discontinued, and that came as a separate editorial in the same paper, 1997. So they had an explanation for that, why they discontinued.
Yeah, I mean, for the youngsters here, mitomycin C is something which is easy to use, but then you should be also aware that it has the potential to give us a lot of, issues down the line, after a lot of years.
So what's your opinion regarding mitomycin injection?
Yeah, last 1 year we've been shifted to mitomycin injection. The Tirunelveli group has picked up in a big way. They do all their injections with mitomycin C injection. We have also changed from December 2021. Very few surgeons here do it as a sponsor. The other colleagues to inject. So in fact, it's injection. We have reversed our surgery. What we were doing previously was.
I think there's a bandwidth issue, Ganesh.
Lift on the strap and then go and do the strap. But now we do the cataract first, close the wound, fill it with viscoelastics, go back to the side, do the trap part, wash the visco and close. It's full. We're finishing in 18 minutes. Now finishes within 14 minutes, the whole surgery. So the advantage has become really fast. For me, time is very important, mainly because I do glaucoma surgery after n number of cataracts. So even 2-3 minutes matter a lot for me.
So Ganesh, I'll just ask you to repeat a small segment because I think your bandwidth got low and the voice sort of, so basically you're not using mitomycin C sponges.
No, we're not using now.
And instead of that, where exactly and how much do you inject?
So we inject mitomycin C about 7-8 millimeters behind the limbus in the superior conjunctiva. And once we inject, we keep a spatula just in front of the injection. So the injection does not, the ballooning which happens doesn't go towards the limbus. We use a spatula and 2 spatulas to push the mitomycin C back for 2 minutes. We wait for 2 minutes. There's no wash given. And then you cut the conjunctiva peritomy and you start the procedure.
What is the size of the needle?
Needle will be a 30 gauge needle.
30 gauge needle.
30 gauge needle.
So it is the concentration.
It's a 0.2 milligram per deciliter, 0.1 millimeter injection. We can take 0.1 millimeter injection along with 0.1 millimeter xylocaine and give the injection.
Now, can you come again? If you're doing a topical trap, then you instead of using water for dilution, you use xylocaine for dilution.
Yeah, you could use it's already diluted. It's diluted to the concentration. You can take extra 0.1 millimeters ml xylocaine.
Then it gets more diluted, isn't it? It gets
but the microgram remains the same. It's 20 microgram which you're injecting. The volume, the weight per volume remains the same.
So that's it. 0.1 ml of 20 microgram mitomycin with 0.1 ml of xylocaine. That is 0.2. Okay.
0.2. Yeah.
Can you use mitomycin C in high myopia patients?
High myopia, it's not usually required. If you have to use without mitomycin C, trap works for 3 conditions which I mentioned. One is traumatic glaucoma, patient with rheumatoid arthritis, and patients with myopia. We prefer to use Ologen. Ologen is not available now, so we do our procedure without mitomycin C.
George, I have a question. I have a question for you. What is your strategy when the pressure, medical management in this primary glaucomas? After surgery, let's say congenital glaucoma surgery has been done, and the pressure goes up. So what would be a strategy henceforth from that stage onwards?
Arup sir, I assume you're talking about primary open angle glaucoma?
Yes.
Yeah. So once
The primary congenital glaucomas.
Yeah, primary congenital glaucomas, my surgical procedure of choice is an angle surgery. We usually don't combine it with a trabeculectomy. So it's a trabeculotomy which we do, and a conventional probe trabeculotomy. And once an angle surgery fails, the options are to repeat the angle surgery combined with trabeculectomy with mitomycin. And then the third procedure is to put in a non-valved implant.
Okay. Yeah.
All along you can augment with medical therapy, but usually for a childhood glaucoma, it has to be
They won't work. Yes. Yeah. We have lost Dr. Girija due to connectivity issues.
Actually, ma'am's network has some problems. She has joined.
Yes, sir, I had. I don't know whether I'm audible.
We can hear you.
Video. Actually, my Wi-Fi had some problem with the Wi-Fi and I got disconnected. So now I have connected through my mobile network. So I cannot put the video on. It becomes very slow.
Yeah.
Sorry, it happened. But I'm lucky. I think it happened towards the end of the session. I could hear most of it. And I'd like to thank everyone, all the speakers who have attended, and for the wonderful presentations that we could hear. Actually, we could learn a lot by listening to you, stalwarts, and so many points. Even for the beginners, you have mentioned even the minutest details. So thank you, sir. All the speakers have done have been very helpful and very cooperative. Thank you very much.
Thank you, Dr. Girija.